Okay, welcome back to this marathon lecture on orthopedics. So far, we've gone through all of the general thoughts I had on orthopedics, going through the courses, going through the FOMED literature, and um, I hope I've given you some kind of approach to the patient. Um, there's one piece of the puzzle for the general approach that is missing in the first part, and that is um, the scared of mnemonic, and we'll go through that in a little while. Because in this part two, we'll go through joint by joint or area by area the the riskful diagnosis that we have to pick up on, but also some common diagnoses. Um, so it'll be great fun, and I hope we can steer through this part in maybe all around 3 or 4 hours as well. Okay, so let's delve into this scared of part first, and then we'll go into the joints afterwards. All right, so the dangerous stuff. As I alluded to in the first part, um, it's kind of hard to say that like it's a spectrum of stuff that we are allowed to miss, and I guess this is general for emergency medicine, but for in orthopedic surgery, I mean, we don't want to miss any fractures actually, but there is this acceptable miss rate, of course, that it's we cannot set it as a expectation that we should not miss any fractures, but um, the main things that we shouldn't like miss are these like really dangerous stuff: compartment syndrome, septic arthritis, and so on. And these things we should not miss either, because they will make the patient function worse. These we will try to not miss, and we'll try to not make the patient immobilize unnecessarily. But these are not. These are the most common stuff that we are going to be exposed to. But and this is where like we shouldn't feel too bad if we do miss these sometimes. These we should probably think of as being not miss. And when I talk about red flags and don't miss, I'm alluding to mainly these things as we go through these joint by joint. Okay, so I thought it might be fun to just from the course we attended, just show you this like the big common fractures, because I always when I start in a new area of the emergency department, it's always nice to like know what are the most common things and what are the most dangerous things. So these are the most common things that we at least need to know some kind of details on, especially how to like these things I was talking about. The information is king. Like what is the prognosis? What are the main treatment options? What happens if we don't treat anything, and so on and so forth. And I'm not saying that I know this. As I said, I don't have that much experience in orthopedic surgery. At least not as much as I have in other areas. That's part of why I also am doing this collection of lectures, so that we can like kind of collect it all and have maybe a discussion about how we're going to do this, and how we as emergency physicians should be aware of the gaps that we might have in these areas. So all right, so the main fracture is distal radial fractures. These make up the majority, like this is by far the majority of the fractures. But then you have your proximal humerus fractures, and you have also this like the closed proximal humerus fractures. So these might, if you add these together, this one and this one, then they might kind of add up. So at least we can safely say that proximal humerus fractures and distal radius fractures are quite common, and we should know about those. Then you have your hip fractures. These are both hip fractures. This is a trochanter, and this is a cervical hip fracture. The only one missing is a sub trochanter, which is not even in the top 10 list, so it's quite rare, or rarer. Then you have your lateral malleolar from your internally rotated wrist sprains and beyond. And then you have your metacarpal fractures and your metatarsal fractures, and then you have your tibia fractures or your lower leg fractures, and then you have in the end your lumbar fractures, usually the osteoporotic patients with a pelvic or a lumbar fracture after falling on their bottom. And I guess this reflects my clinical experience as well. You do see your odd scaphoid fracture now and then. That's really common as well. So at least immobilize people for that. You do see some of the, like, it's not like the stuff outside of the top 10 are uncommon, but there are certain fractures that are really uncommon, and it's important to think about the fractures as why are some fractures uncommon? Well, if you do see an uncommon fracture, then it has to have involved some kind of uncommon mechanism, or the patient has to have some kind of uncommon risk factor. Not necessarily, but it's like if you think of it as in a Bayesian way as well. It's kind of, well, if you have it, for example, a talus fracture or a calcaneal fracture, and you say it's a low risk injury, well then suddenly, well, how did that happen? It's maybe the story doesn't fit. That especially when it comes to children, that is important. When there is a discrepancy between the story and the seemingly like quite big fracture, that would be a big red flag for non-accidental injuries or like child abuse. Okay, so getting ahead of ourselves here. These are the common fractures. Then you have your don't misses, and you don't miss. There are some infections that we should not miss. Your necrosizing fasciitis, your septic arthritis, and your flexor tenosynovitis, along with your V. phlegmoni. Then you have your fractures. There are certain fractures. The beak fracture, like a big calcaneal fracture, is like open like a melon. These are really bad, and Cotton, a doctor in 1916, said that the man who breaks his heel bone is done for so far as his industrial future is concerned. So this is a really important fracture. I know the Swedish are really, as I'm told, are quite aggressive with these. I think the same thing applies to the Danes, but we might. I can see on the orthopedic surgeries like guideline homepage in Denmark, they allude to being a bit more conservative unless it's a really big calcaneal fracture. So I guess these might fall into that category. Then you have your open fractures, your Gustilo-Anderson fractures above 2, it should say. You need above 1. Yeah, you need antibiotics within 3 hours. Okay, then you or as fast as possible. You don't want to miss your compartment syndromes. This rule of thumb is if it takes longer than 8 hours, then it's too long. Within 3 and 4 hours, it's salvageable. If it's within 6 hours, then it's somewhat salvageable. And think of how long it takes to fix operation, call anesthesia, all of these things. It takes a long time. So this is against the clock. Cauda equina as well, and cancer-induced myelopathies takes a long time to arrange. These we need to be very cautious about. This is a syndrome where it's really hard to pick it up usually because we don't have the access to MRI usually. It might be different in different areas of Denmark, but anywhere I work in Denmark, it's always a battle to get the MRI. And we'll talk a bit about how to maybe differentiate the back pain with bladder symptoms from the cauda equina. Your dislocations, especially the knee and the ankle, you don't want to, because of vascular injury, you don't want to miss these, and you don't want to, knees especially, ankles are usually quite obvious, but knees can be 50% of them are look normal when they come to the emergency department, maybe besides a bit of swelling. And it's important to actually pick them up because of the vascular injury. And if there is a vascular injury, then they might lose the leg if not treated. And then all kinds of vascular injury is also a don't miss. Okay, so these are the general don't miss these. There are a few more. You can always go into infection. There might be diabetic foot, plantar abscesses and Charcot foots. You should not miss those either. So, but this is like the peak that really like don't miss these. And you can talk about also like certain fractures like C1 fractures. Don't miss those, of course. But it's hard to talk about all the spectrum in orthopedics. It's not like talking about other areas of emergency medicine. We don't miss this, because it's such a all body thing here, and it depends, and so it's a spectrum. But these are at least a list of stuff that we should not miss. This might be a bit problematic, and this is something that is general for emergency medicine. These next two slides, but I'll use necrotizing fasciitis as an example. So let's say that you have all patients with necrotizing fasciitis in literature and has ever existed. So what we gain from the literature is usually the typical illness scripts, all right? How it typically presents, and we can calculate so many percent presents with this, so and so many percent presents with this. So we get like a average person. But the patients that present to us, none of them are average. None of them are average. And there will always be, like, there's this great book called How Doctors Think by Catherine Montgomery. And she argues, among other, that there will always be a discrepancy between the typical picture, like in the books, and the way that the patient actually presents. So if we think of these as two patterns, the way the patient presents and the way the way the illness script, like the typical illness script, is made in the books and the literature, there will always be abnormalities that stick out. Oh, this patient with this, it wasn't pain out of proportion, like really, and it was a bit other, there's some other stuff, and there will always be abnormalities, and because of that discrepancy, that inherent discrepancy between the illness script and the condition that the patient actually is presenting with, there will always be an uncertainty in the way we practice medicine. That's an irreducible uncertainty. There are other kinds of uncertainty that are reducible, like knowledge, lack of knowledge, or cognitive biases. These are uncertainties that are reducible by education and by practicing and simulation and so on, what we're doing now. But there are uncertainties that are irreducible, and that's the core of that is partly because we are, like, when we're kind of gathering evidence on gathering knowledge, this is from a average patient, and there's no such thing as an average patient, and we will have to interpret what they're saying. And I've made an entire lecture on how we do that, how we communicate that with patients, and why that is so important that we actually get this stuff right. What are they saying? What is their problem? What are they actually saying? So it's quite complex to adapt what we know to what we're seeing, and I often think that is often missed. Okay, so it's just to start off with this don't miss kind of thing. It's hard. It's difficult to not miss stuff, and we should talk about what you might say, like if we really want to never ever miss anything, then we should scan everyone, like, and we should do biopsies on everyone all the time, and that then we go into like a harmful picture, right? So if we don't want to miss all the like if you take necrotic fasciitis, well, if the typical picture is like this, is the brunt of it, is like, I don't know, 50, 70. I mean, we could put it down here as well. Then it's like 75%. But then the last 25% or maybe 10%, they will present in such an atypical manner that from the get-go, it's really, really hard to to diagnose this. And if all patients with some kind of redness, if all of them should go through like fasciotomy, that would be crazy, right? But that is sometimes what is required when the signal to noise ratio goes so far down that it's really atypical. So and this goes for all diseases. And here I've said that we have a really like nice bell curve where you have the brunt of the symptoms right here, like the brunt of the patients are here. But maybe there's conditions. We know that all conditions have a different slope here. Some of them are really flat. So uh, there might not be any peak features. There might not be any really common features. A lot of maybe there's like 30% for this, 20% for this thing, and then the slope is not that high, and then it's really hard to actually diagnose these. Then there's a lot of signal to noise, and then it has to be quite advanced before we can actually pick out the noise from the signal, or the signal from the noise. So if you take EM cases here, the early signs of this would be it would be pain out of proportion. It would be skin necrosis. It would be edema. It would be blisters. It would be crepitus. It would be skin hyposthesia. It would be rapidly spreading rash and SIRS. So, for instance, at our course, the teacher said, like, these patients with necroticizing fasciitis, they always look septic. Like, think about that. That's what they're saying is that, and I'm not saying they're wrong. I'm just saying that if you think about that from a like sensitivity point of view, then that means like, well, SIRS would be kind of 100% sensitive, which I'm sure it's not. For necroticizing fasciitis, I'm sure that there's a lot of patients that only have pain out of proportion, or only have edema, or only have, and that's what I'm getting at. I think, like, the patient who has a high signal, they are like, who fits the like typical big picture, they're the easy ones to pick out. Then it's a matter of lack of knowledge usually if we don't pick them out, or like system factors or cognitive biases and so on, contextual factors. But if they only have one of these, maybe pain out of proportion is quite a high signal. But if they have, I don't know, if they have only have SIRS, but they don't have like really clear, they're an old demented patient that we can't really see the entire picture. They can't really explain why they're hurting or where they're hurting. They're just screaming. Then it's atypically presentation, or at least high signal to noise, higher noise to signal ratio, right? Very noisy picture. Then it's really hard, and then it's going to be, I mean, then if we should examine all of these with fasciotomies, then it's impossible. So I think the bar of never missing anything, any of the don't misses, I don't think that's a good way of doing it. I think Eric Driver's way of thinking about these things are better. Like, if the data is there, and it's not like, a miss would more likely be like if we have the data and we're not using the data, then that's a miss. That's much more like a cognitive bias kind of miss, or we don't have the knowledge that the data in front of us actually is something that we should think of. And like we should think about necrotizing fasciitis when you have pain out of proportion, you have a maybe diabetic patient and they're septic. Well, then we should think of it. That's a miss in another way than missing the rare occasions. Because would you use a general rule for these patients that present atypically? You couldn't, like, at what cost are we testing all of these with just one of these things for all of the bad stuff, right? I'm not saying we shouldn't be aggressive if they have like high signal like SIRS or them, but why should it be this? We should. I think you might be getting what I'm saying. So so in this from EM cases, they also say like consider necrotizing. What they say like do consider necrotizing fasciitis in healthy patients after minor traumatic injury, and what they say don't rule out necrotizing fasciitis in the patient who looks well. Yeah. So I guess it's not 100% sensitive, this. And what I also guess is, well, if they look well, does that mean they don't have pain out of proportion? Does that mean that they don't have blistering? Does that mean that they don't have any of these features? I don't think so, but that would mean that there's a lot of these that we should consider, and that it's impossible. We have to filter somewhere. So, yeah, just my thoughts here. And here was my example. If the landscape looks totally different, this might not be necrotizing fasciitis, but maybe aortic dissection, like where the spectrum of this, like the spread, is different, and what is typical and what is atypical is quite the same. Okay. Just reminding you that we're talking about base again. And now we're going to why this base is important, because now we're going to the scared off mnemonic. The scared off mnemonic is something to think about. I've had my own, I never used it as a mnemonic like that, but I had a list of things that I would not like to miss in any patient, no matter what kind of joint it was, whether it was an ankle or a back pain. Always think of these things, because when it comes to minor trauma or even major trauma, these are the things that we should not miss, and which could be negative on x-ray. So that's Aaron Sale had put it together in the scared off mnemonic, and I borrowed it because it's a nice mnemonic, and it overlaps very much with what I've always used. I've added the neurovascular part, but otherwise it's the same. And I've added a few bits and bytes for this. So the S of scared off is the septic joint. Is the S for septic. Necrotizing fasciitis. Post-operative infections, I would also say. Open and closed fractures. Costello-Anderson. And diabetic foot with infection. Osteomyelitis. And plantar abscesses. And C for compartment syndromes. Compartment syndromes are usually in the forearm or the lower leg, but it can be anywhere in the body. One of my colleagues have had a patient with a compartment in the back, in a back muscle, because of steroid use. So it can be in any kind of muscle group. But we'll go into how we assess that. Then NI, or non-accidental injuries, or child abuse. Okay. Then RE, which is referred pain. We need to be able to reproduce the pain when we are examining a patient, as we alluded to in the first part of this lecture. If you don't, then you have to think about, is it referred pain from somewhere above, medical course? If it's shoulder or elbow, maybe it's ACS. If it's shoulder, maybe it's gallstone. If it's if it's your knee, maybe it's your hip, and so on. And then RE is also read wrong. And that's where our NCRs is maybe around 1 in 5 are read wrong. The X-rays are read wrong, but I'll just say, well, read your own X-rays and you do the AABCs. Okay, dislocations, especially in knees, has been in and out, but also the olecranon and other dislocations, they will not turn up on X-rays always, especially if they're reduced already. The knees are really important not to miss because they might have vascular injury. There are differences here, like patellar luxations. They might have also popped in. It's not as dangerous to miss those though. The elbow, the shoulder, and you have operative soft tissue injuries. That would be in the shoulder. That would be like total rotator cuff injuries, especially in young patients, and distal biceps injuries. Then you have in your finger and joints, you have ligamental injuries, your TFCC injury, which is called distal radius ulnar joint injury with the TFCC ligament, or the purulunate dislocation, and the volar finger as well. Just these, again, it's hard to do an exhaustive list of this, but it's just a rule of thumb list kind of. Knees, like operative soft tissue, like locked knees, quadriceps, and patella tendon and Achilles tendon ruptures. And then occult fractures that are either hard to pick up or impossible to pick up on X-ray. The classical example would be scaphoid fractures. Use your pretest probability and your clinical examination. If you think there's a fracture and it doesn't show up, consider CT or immobilizing the patient and close follow-up. And then I usually put on neurovascular injuries as well. Check the pulse and so on. And neurovascular, go through the motor and sensory. Okay, and then I'll go through some of these conditions that doesn't really fit to any joint. And all of these are mainly done in Danish. Sorry, I haven't had time to translate them, but I'll translate them here for you. So septic arthritis, you'll think, like, epidemiological speaking, the higher risk if the patient is immunosuppressed, there's immunosuppression like diabetes type 2, or they might have some kind of synthetic material in the joint. The tests that we can use are usually the history is non-traumatic musculoskeletal pain in a joint. We might look at where the joint is placed. If they're trying, especially in the hip, are trying to open up the joint to reduce the tension. That doesn't necessarily say that it's septic. It might just be a swollen joint. If they won't bear weight, that's a red flag as well. And if the pain is worse with along with the range of motion. So if they're rotating in the joints, then they will usually hurt. So when it comes to vitals, they can be afebrile, these patients, easily, and this is where it really becomes difficult, because then you can do blood samples. The CRP doesn't have that much strength if it's above if it's about 10, then it's like a ratio of if it's not above 10, then it has then it has a likelihood ratio of 0.3 to 0.6. So, I mean, in general, the blood, all of these is it's the small components. There's no one test that can rule out or in this thing. Usually, you might do some kind of X-ray, but it's low sensitivity. You might do POCUS, but it's also low sensitivity. especially for certain joints. So the gold standard is tissue culture. So what you will actually usually do is, if you have a septic joint or you're suspecting a septic joint, then you will puncture it, and then you will send the synovial for lactate especially, and the other test, like see if there's crystals. Even if there's crystals, doesn't necessarily rule out a septic joint. But yeah, of course, all of the basic stuff, like is there swelling, is there all of the other things, is also part of this, right? If there's a high risk patient with a non-traumatic injury, and then you do your, like if you have a high enough predisposability, and you don't suspect any other conditions, then you'll do your punction. And the punction might be done by ultrasound guided through radiology. And then you might think, oh, what about antibiotics? But usually antibiotics can wait. At least if you have this patient during the night shift, antibiotics can wait. Because if you start antibiotics too soon, then the cultures will for this thing will be false negative. Like I think it's what is stating, maybe I don't know, 40 or 50%, a lot of the times. So it's worth the wait. It doesn't increase the risk, it seems, that much to just wait a couple of hours to get the joint punctured and then start antibiotics afterwards. But if it's more like, if it's 6 to 12 hours you have to wait, then probably you have to do it, start antibiotics anyway. It seems like certain joints are hit more than others. So it seems like hip joints, knee joints are more common, and it seems like gout hits more distal joints. But the problem is that, like, there's an overlap there where gout might go more distally and arthritis might go more proximally. There's an overlap there around the knee. So, and any joint can be hit. We've had cases of sternal septic arthritis as well, sternoclavicular joint. So, okay, open fractures. The definition of an open fracture is an osseous disruption in which a break in the skin and underlying soft tissue communicates directly with the fracture and its hematoma. Meaning that, well, there's a fracture and then there's this small, like there's a break in the skin, meaning that the outside can go directly into the broken bone, right? I was originally taught that any skin break anywhere, even if it's far away from the fracture, could mean that this is an open fracture, but it doesn't mean. It has to be in relation to the fracture, but the relation might mean that the fracture could have like reduced, and like the hole in the skin, like the hole in the skin has to be done by the bone in general, or there has to be some contacts somehow, is what I've been told in this course at least. So if you have a scratch on your leg and there's a fracture 20 centimeters distal to that doesn't mean that these are connected like that. But keep up on your local protocol on that. So important epidemiology is 10 to 20% of open fractures have a vascular injury. 10% have a compartment syndrome, even if open. So it's really important that open fractures do have compartment syndromes as well. Just because they're open doesn't mean that they've been relieved in that compartment. And always look for second fractures. They're often missed. And look, like the inspection is really important, so that with any fracture that you don't miss that there might be an open fracture. The management is analgesia and sedation, and reduce if needed, especially if it's an angle fracture. And hemostasis, if it's really open, and antibiotics within 3 hours. Think of the contaminants. What kind of antibiotics you will use depends on the Castillo-Anderson degree, and also what kind of other contaminants might be involved, like farm animals or water. Remember tetanus? You don't need cultures. They don't really seem to get what you're going for. It doesn't change management. That was according to our lecturers as well. Always think of neurovascular injury and compartment. If it's obvious, then reduce it. And if it's occult, then do sequential observations for vascular injury. And by reducing, I mean reduce the angle if it's in a bad way. If it's purely an vascular injury, then you might have to do, as I said, around vascular injury examination, do hemostasis, tourniquet, try to and last ditch effort is put a straw between the two ends so that you might keep up perfusion until surgery can come down. This is important. Clean with minimal water. Only clean macroscopic dirt. You don't have to, and then apply afterwards a damp dressing. Not a totally dry, but just a damp, not a wet dressing, a damp dressing. Because what it seems like is that you should avoid high pressure water. Don't spray water into the wound, and avoid large amount of water. As one of the lecturers said, the tissue when they operate on it is like tofu if you put a lot of water in it. So keep it damp. Only put as much water as put as little water as needed into it, and then consult ortho. There are different classification systems for open fractures. There's the MES, which we usually don't use in Scandinavia, as I'm aware of. It's about whether or not it should be amputated. What we use is usually the Castillo-Anderson, and the Castillo-Anderson is mainly a risk of infection and need for antibiotic kind of score, and it goes from 1, 2, and then 3A, 3B, and 3C. And this is a really important line to be drawn because this is where you have vascular injury and where you need to use antibiotics. You can sometimes use antibiotics in these, and almost never do these. What kind of antibiotics you use, depending, like in general, I think in Scandinavia you only have one, and then, but in general, as the bigger it is, the broader you have to use. Yeah. Okay, so important rule about the Castillo-Anderson: all high energy trauma, they are 3A or above if they have a nick on the skin and a fracture. So like if they live up to the definition of open fractures, then all fractures above 2, meaning 3A and above, they are all high energy trauma are 3A or above. Okay. So the type 1 would be, that's a clean wound below 1 centimeter. Just treat as a non-open fracture. Just close the wound with a suture, and then you can. Then usually you don't have to give them antibiotics for this, but there are some caveats there, I think. So the inserrator reliability here is a kappa value of 0.6, which is quite bad. And this is among I think it was among orthopedics, orthopods, orthopedic surgeons. So if even they disagree on like inserrator reliability between 1 and 2, then there's a high risk that I am missing a 1 for a 2, and that's important because they need antibiotics and they don't. So if you're not sure, then give antibiotics. I think from this literature, I would say then just give antibiotics. There's also the bite fight. The bite fight is usually a small wound that is clean, where the patient has like hit into someone's mouth and got a small wound around the joint. If the open wounds are around joints, especially in the hands, then it's really important to give antibiotics. The hands are a bit special in this area, and we'll come back to that. But they infect more than other areas of the skin. All right, so then you go to wounds above 1 centimeter, and you will still suture if possible. And then usually, often you will need some kind of operation. You have to call your surgeon, and then insert antibiotics within 3 hours. This is the most important thing about this. Antibiotics within 3 hours. Then you can always fix the rest. Then you have your high energy trauma, and this is where we get into catastrophic area. All of these have to be contacted, like admitted, and check for vascular injury, compartment syndrome, neurovascular, neurological injury as well. And then it's also just about when to do a revision of this. And these you'll do right away, these you'll do within 24 hours. But in general, if you have high risk injury, high energy injury, you'll just call your orthopedic surgeon, call vascular surgery. Or maybe not call vascular surgery, but admit for vascular and neurovascular observation. Yeah. Okay. And then we have necrotizing fasciitis. I've gone through this already in a few slides before. So the main causes, the main symptoms would be, like for the classical illness group, is severe pain out of proportion. A minority of pain, however, a minority of patients will report little pain or may have a laissez-faire attitude towards their illness. It's like, it's nothing. All right. So, but it depends. You need to know what kind of is it a stoic patient? Well, then you need to be aware. Then you have ecchymosis or skin necrosis, tense edema, like almost a wooden kind of feeling of edema, and bullae or blisters, palpable crevices. Might not always might not always be there, depending on if it's a gas producing or not. Then localized skin hypothesia, and those due to local nerve destruction. And then a rapidly, like, I think pain out of proportion, and a lot of these are obvious, like somewhat obvious bad signs, these like local skin conditions. Then you have, but I think pain out of proportion and rapidly these like rapidly becoming worse, and pain out of proportion, I think those are some of the ones that I probably would pick it up on, because these are probably highly specific but not sensitive. These are probably more sensitive but not specific. Okay, and I think that's fair game. SIRS and rapidly spreading infection with pain out of proportion. That's good. That I can catch on a good day probably. It's always about context. Okay, so the pitfalls that they talk about here is that assuming no necrotizing fasciitis, even though the patient looks good, ruling out necrotizing fasciitis based on little pain, no fever, or no crevices, and delay surgical debridement. And what is important, what they usually say is like scrutinize the vitals, because the vitals, they usually have tachycardia out of proportion, or tachypnea out of proportion to their fever. And if you see cellulitis like in the perineal area, then it's usually, then you have to think about the Fournier's gangrene. Again, a lot of this is probably cellulitis just, but you need to contact someone if it's really pain out of proportion in someone. Okay. And then they have this finger test, and I've never used this, but you If you're not quite sure, then you can use a small incision into the fascia, um, and then see if there's like dishwater kind of muscle running out, like gray kind of like dishwasher push kind of running out. The incisions should only be like 2 or 3 centimeters large, and then it might be suggestive. It's not a test that can like rule it out, but if you have a suspicion, but it's a quick test that can be used. But I'm not sure if we should use it in our departments. Okay. If you find it, then you will contact a surgeon, depending on the local guidelines. Maybe the plastic surgeon, maybe it's an orthopedic surgeon, maybe it's a abdominal surgeon. Usually in Sweden they kind of haven't agreed on who takes it, which causes delays sometimes, sadly. But meanwhile they're fighting, then you'll start some kind of antibiotics, usually quite broad spectrum, depending on the cause. Okay. Diabetic foot attack. When we were at Danish Emergency Medicine Conference, there was a great lecture about the diabetic foot, which is usually under appreciated. So I just wanted to say a few things about what they wanted to call a diabetic foot attack. So if you have a patient that is diabetic and presents with a red foot, that is a red flag. And then you should think about 3 things. If there's fever or signs of infection or erysipelas, then that's one category. The other category would be if there's no signs of infection and there's a really red foot, then that's another category. And then the last one is like it's more like black areas than red. Okay, so the first one here would be erysipelas. Well, most patients with diabetes will get that at some point. Osteomyelitis. Most patients actually do have osteomyelitis to some degree if they have advanced diabetic feet. We can do a CT scan and then they will be admitted and then you'll give antibiotics, but usually what you really don't want to miss is the plantar abscess. And usually there will be tender in the sole, and if you like dorsiflex the foot, it'll hurt like hell. And it's like it usually be like it is usually obvious, but as we said, like some of the obvious stuff may present or some of the don't miss stuff may present atypically. So if you have a patient with fever on a red foot, then you should really have a lower threshold to do a CT scan for osteomyelitis and plantar abscess and admit and on antibiotics. If the patient has a red foot and you raise the leg and it blanches after 10 minutes, then it might be a Charcot foot. Do a CT to confirm, and then immobilize. That's the most important thing. Immobilize so that the joint isn't destroyed. If they keep walking around on this, I can't remember, but there are certain studies that says like for a few weeks, then it will be destroyed. Yeah. And then local guidelines will guide whether or not you have to admit them or you have to send them for some follow-up, depending on whether they can actually live up to what you were saying. You're immobilizing them. So are they someone who can actually carry out their ADL at home, or can't they? And if they have black areas, then it's usually necrosis or ischemia. Might have, along with their diabetes, they might have vascular injury of the foot, and they need to be consulted with orthopedic surgery sometimes vascular surgery as well. All like what I'm no specialist in this area, but what I think the takeaway is red foot, diabetic, then you have to think about these things always. Okay, and the don't miss is plantar abscess, somewhat osteomyelitis as well, and then the Charcot foot. The necrosis and ischemia is usually quite obvious, at least the necrosis is. The rest is usually benign ulcers. The foot is not red there, but they might have some sores, but they don't look infected, and they should just be followed up by their podiatrists or the diabetic outpatient clinic. Okay. Compartment syndrome. in general, compartment syndrome. The reason why we develop compartment syndrome is that there's increasing pressure in one of the muscle compartments, and then it doesn't take that much pressure for the venous return to be clot off. That will just make then blood cannot escape, and that will build up pressure, and that like a vicious cycle has begun then. And usually we think of that there has to be a lot of pressure, but for like the compartment syndrome to begin, I think EmergencyMedicine says something about it's like maybe 15 millimeters of quicksilver for it to begin, something like that. And before you get all the 6 P's, like the pale, like peripheral neuropathy and so on, then it has to be like a pressure of 100, 120 or something like that. It's like so late in the pathology, so it's not useful clinically. Around 70% of the patients with compartment syndrome has a fracture, but 30% don't have a fracture. It might be a tight cast, it might be a crush injury or burn wound, like a circumferential burn wound. It might be excavation, what's it called? It's excavation from vasopressors, like going into the tissue. It might be an elderly alcoholic lying on the floor for too many hours. It might be bodybuilders injecting steroids, as we talked about. So don't rule out a compartment syndrome if it's not a fracture. And remember that open fractures have compartment syndrome in 10% of the cases. The highest risk is the tibia. The tibia is the highest risk, and that's and the problem is that we'll get to which compartments in the tibia are hard, but in general the anterior and lateral compartment are the most common, but there's a deep compartment that you cannot get to by palpation, and that's really tricky. The second, by a long margin, but the second most common is the forearm, because both of these places, the forearm and the lower leg, have tight compartments and not a lot of space, but a lot of muscles running through them, because they keep all the muscle bellies for the foot and the hand in that area. Okay, then there is some, like EM cases would say, Sayal would say that if you have a well-trained young man, kind of like with your epidural hematomas, then they have just like they have a lot of brain and a little space, then they all, like when it comes to compartment syndromes, then they also have big muscles and not a lot of space. But that doesn't mean that you should not rule out anyone who's not, like it could easily be the small elderly female who's been lying on the floor for a long time. And the area, like it can be developed anywhere. Compartment syndrome, it doesn't have to be the lower leg or forearm. And then how do you diagnose it? Well, you always think of it, right? That's why you have to be able to, in your general assessment, palpate the compartments of at least the lower leg and the forearm. Traditionally, we've been taught the 5 or 6 P's. They don't really work, as I just talked to you about. Like always, like 30 millimeters of quicksilver and 150 is where you get the muscle paresis. So forget those. If a patient is in a higher risk area, and then you can usually, it's a clinical diagnosis, right? Forget the striker needle. It's not something that we should be using clinically. It has a higher inter-rater reliability. Is really bad inter-rater reliability, and it's hard to use and so on. So what we should think about is, if the muscle compartment is hard, like a wall, like almost wall hard, and if there's pain out of proportion, especially if it's becomes worse if you passively stretch the muscle belly, and if it's morphine resistant. Those things are enough just to activate operation now. And then of course pain if you palpate the specific compartment. And then if you need anyone, like if you need one more P, then it's usually the peristhesis, but don't wait for it. These are enough. Pain out of proportion, especially. Pain out of proportion with a hard and tender muscle belly, muscle compartment, and when you passively stretch the muscles, then it'll hurt like hell. All right. Treatment is put the leg down, because then you will increase the pressure, the perfusion pressure of the area. Remove all outside pressure like casts, cloth, stocks, so on, and call orthopedic surgery right away. If you just put your patient in a cast, then put the cast away and then assess in 10 or 15 minutes. If the pain hasn't gone down, then you treat it as compartment syndrome. Okay, so we were given this rule of thumb, like 3 or 4 hours of compartment syndrome from injury to diagnosis, 3 or to knife in the like the fasciotomy. Then 3 or 4 hours, then it's almost always reversible, almost fully. That's not a lot of time. Then 6 hours, then it's somewhat reversible, and above, this is actually important, above 8 hours, around 8 to 12 hours, then you can get what you would call crush syndrome if you do the fasciotomy, because then you are in high risk of letting all kinds of ischemic injury toxins, hyperkalemia, rhabdomyolysis, and so on, out into the system. So it's better to just leave it at that point. That's at least what we were told here in this course. So these are this is how we were taught, and this is partly also EM cases talking about this like this. And once you open it, it was like we were told. I've never seen it being opened, but what I've heard from someone who has, they usually say, like, do you know these like croissants that can be popped open? Well, it's exactly like that. When you it's like suddenly you have a lot of stuff flowing out of when you put the needle into the fascia. You're not in doubt. Okay. So just so you know where the compartments are. So this is the lower leg. You have your anterior compartment. You have your lateral compartment. And you have this posterior compartment. And then you have this tricky compartment in the middle here, which is seen here, the deep posterior compartment. And that's a problem because you can't really reach that. You can see the tibia is in the way here, and the fibula is in the way there. And the other compartments are in the way here, so you can't really reach that. So have it, like, you might be able to activate some of the muscles here by passively moving the leg, but this is like tricky. Most common ones were these. In the forearm, it's all the compartments are reachable. There you have an anterior, you have a flexor, an extensor, and you have your mobile. Okay. Then another thing which we should always think about when we have a patient is the elderly. Was this a mechanical fall or was this a geriatric decompensation? What do you mean by that? Well, I've done a blog on this as well, on Acute Medicine on our blog, about the elderly patients. And I've also written a chapter in the Danish emergency book about this, along with Christopher Bock-Hattingen, a friend of mine, and who's a geriatric resident with a special interest in emergency geriatrics as well. So what we what I want to talk about is just the geriatric syndrome, and how the doctor should see the geriatric syndrome as a canary in the coal mine. Geriatric syndromes would be like delirium, that's a geriatric syndrome, would be like a mechanical fall, quote unquote mechanical fall. It might be like causa socialis, like cannot take care of the ADL anymore suddenly. These are like canary in the coal mine. If an elderly patient that is not frail suddenly develops these things, then that might be the canary in the coal mine to tell us that, okay, that patient actually is on a pathway to frailty and disability. So we should, once we've treated that cause, like the acute cause, then we should try to optimize all the other stuff through their private practice or geriatric outpatient clinics. Okay, so what do I mean about the decompensation? Well, okay, so if this is a this is from Clegg on frailty. If this is the y-axis is your daily ADL, like how can you function, and this is time on the x-axis. Then you have a patient who like if you have a high function here, then you are independent. You can do whatever you want, and here you can't do anything. You need help from others. So if a healthy person, a young healthy person, gets a disease like a UTI, then they will get the disease here. They will get a small decrease in their daily function. They might not be able to reach the toilet in time, or they might something. Then they will get the treatment, and then they will recover fully within really short time. If an elderly, like with chronic frailty, your baseline level of ADL decreases. So frailty would be more and more comorbidities or higher age, especially biological aging, where you cannot move, where you cannot like do a sit up and go test. Like you cannot squat down on a chair for a couple more than I can remember. There's different tests for these, like how frail you are, and it's usually a combination of age-related stuff along with comorbidities, and like and in a short, you can call it biological age. So with increasing biological aging, you go to your baseline will go down, and once your baseline has gone down, then usually if you get the same kind of UTI, then you'll become much more debilitated by the same kind of UTI. There's a much bigger drop here than it was here, so you'll get much worse off here, and the recovery takes much longer time, and you might not get back to your previous baseline. We often see patients getting admitted again and again and again and again until they are like their baseline is below this level of independence. This line here I usually call the decompensation line for elderly patients. If they get below the decompensation line, then then they will usually present with some kind of geriatric syndrome. They might present with UTI symptoms, but usually they won't, because they won't be able to explain that to you, because usually they will either fall. That's like they will fall when they go down here, or mechanical fall, or they will not be able to take care of themselves, meaning that they won't be able to drink, meaning that they usually come in with kidney failure, or they've somehow taken their medications but not been able to drink, so they have some kind of lactic acidosis because they only took the metformin, or they might have delirium, or all three, usually all three. And it's so important for like this is like the majority of patients that we see that have decompensated below their own, and so what we have to ask when we are faced with a patient with any of these presentations: delirium, mechanical fall, or loss of ADL, sudden loss of ADL, activities of daily living, like being able to take care of themselves. We have to ask them, why did that happen today? And especially with delirium, it has its own workup, but it's kind of the same things that we are looking for. So you have your frail older patient, and we might not know that they're frail. The patient, the family would usually say, "Oh, but they're walking around. They're not frail. They attended his birthday." Yeah, but like the test for frailty is usually that they get into the hospital. They had a mechanical fall. They didn't actually break their fall with their outstretched hands. They broke and hit their hip, something like that. So this is and then the fact that they can decompensate by just having an UTI is often sometimes also like evidence of frailty. Or if they've been admitted several times in the last couple of months for minor conditions or for infections or something like that, that also seems to be like they're really getting below the they have a hard time getting back to their baseline. And usually that's at that point, that's where they lose weight, they get sarcopenic, they cannot move because they're lying in bed all the time, and then suddenly they're not the same as they were 3 months before, where they seem to be able to take care of themselves at home. Oh well. But okay, so when we meet this patient, then the frail elderly patient who fell, we should think of, okay, they're fallen. What kind of stressor? Why did that happen today? They don't usually fall. They do live at home. They're not decompensated at home. So why did they fall today? And it's really important to think of this in. You can think of this like, it's not important of how you think of it. Just think of it, and then take the blood samples that you need to actually rule out infection and all this other stuff. But you can think of it like this: there are intrinsic factors like the aging and comorbidities, such as balance and vision and proprioception and cognition. Then there's fewer falling. There is sarcopenia, osteoporosis, and polyneuropathy. These are like patient factors that comes with aging and comes with certain behavioral and life circumstances and so on. But then you have your intrinsic factors, and that would be the environment. So how are they living? Are they and are they suddenly in a new environment? Then usually they might develop delirium if they are in a protected environment where they know everything, and suddenly they're not. Then that alone can sometimes, if it's a frail patient, get them to develop delirium. But what we need to know about as emergency physicians is what kind of acute stressors are usually the ones. And if you want a broader look on this, then you should check out Christian Nichol's the European book on emergency geriatrics, or check out Simon Conroy's lectures. He's a geriatric expert with a special interest in emergency geriatrics in England, who's made some of the biggest progresses in emergency geriatrics and their own geriatric emergency department. Anyway, we should look at medication. Check the seponeringslisten from in Denmark, and then stop all medications that they don't need, especially hypertension medication. Usually with age, the risk-benefit shifts, and you should probably not use it as much as we are doing. Then look at sedatives. Be careful of just getting the patient off the sedatives, because they might develop abstinence. But think of it like something to be aware of at least. Delirium and anticholinergics are really common combination. So, and there's you can check these anticholinergic load things. Lists where you can actually check and some of the common ones like antihistamines for sleep or for allergies, like this can like get this is like grade 3 anticholinergic. They can really mess with the patient's head, so and get them delirious. Any polypharmacy, meaning I think it's above 5 drugs, it's a problem as well. And then we look for infection. We look sometimes for ACS, electrolytes. ACS, not as much, but mostly infection, electrolytes, and others. So usually we'll take like maybe infection counts, electrolytes, creatinine, and see if they have any problems there. If they don't have any obvious like chest pain, then usually I don't. It's important to think of the more frail they are, the less stressor they need. So it actually also goes for patients with disabilities, like neuro disabilities, like it could be patients with Down syndrome or stuff like that, or like low functioning patients who are in homes. If they get new personnel, if they get obstipated, constipated, or if they have pain, then that is enough for them to decompensate and become delirious or become different according to their carers. So it doesn't have to be this big dangerous stuff. Then syncope versus fall. Sometimes you say like, oh, it's a mechanical fall. Well, what happens? You then ask, and then I think I fell, and if they say I think, well, then they are not sure, and then they should probably work it up as a syncope actually. So take an ECG and consider if they need to be worked up further. And then you can think of the environmental stuff like dehydration and so on. So we have to think of these acute stressors every time we have a mechanical fall in an elderly, potentially frail patient. And we know which is at least in the hip fracture patients, but also some of the Fuchs patients. We need to think about these things as well. These things we have to optimize and follow up, right? So once we've dealt with this, which is our responsibility and the admission during the admission, but once we should also like follow up on the more chronic stuff so that they actually get what they need and get their primary practice physician to, if they've suddenly fallen, that means that they're demasking their frailty, and we should work them up and then try to optimize their home so they don't have to fall too much, because as you know, hip fractures kill, not necessarily causally, but it represents that the patient is probably frail. They really need to be modified in these areas to gain more life. Okay, so now we're moving on to the specific joints or areas of the body, and we'll go through them one by one, and what kind of diagnoses that you need to look out for, don't miss, and how you should build up your examination of the patient in these in every specific area from this like list of don't miss differential diagnoses. This is not a complete list, but I've done my best to show you what kind of diagnosis that, at least according to the FOMED literature and to the courses that we've been on, are some of the like don't miss diagnoses. Besides the always relevant don't miss diagnoses that I just went through, that are specific, that are non-specific for any area, like compartment syndromes, like septic arthritis and so on, even though they have a higher probability in certain areas of the body, like compartments in the lower legs. They can exist anywhere. So now to the specifics, the specific areas where we just went through the general like red flags and don't miss diagnoses. Okay. So as I have alluded to the entire lecture, anatomy and knowledge of anatomy is quite important in orthopedic surgery. at least knowing what kind of bones you're pushing on is quite important. And I'm not going to do a comprehensive anatomy lecture, but I'll I'll bring in some anatomy in the lectures in each area. And when we talk about anatomy, it's not only like bone anatomy, it's also surface anatomy, like how do we know on the surface of the patient where this bone is or where this joint is and where it ends, and how do we push a needle into that joint if we need to tranquilize it. And it's also X-ray anatomy. So there's lots of like, and even it may be ultrasound anatomy as well, though it's not as important in musculoskeletals as it is in other areas. So I would encourage you to check out some of these links if you're a bit rusty, as I certainly am, from time to time in specific areas of the body and anatomy. And as the emergency physicians, we can't know all of this stuff all the time. So I'm not saying that you should go into a very detailed level, but especially for some of the areas where it's high yield, we should know some of the anatomy. That doesn't say that you should know all of the wrist bones all the time, but at least you should know where the scaphoid is, and probably also the lunate and maybe the hematum and so on. Okay. So one of the there's one I didn't put in here. There's a FOAMed guy from an Irish FOAMed page who did SMAC, and I forget his name, but I'll link it I will put a link in the description instead. Who does anatomy videos for emergency physicians that are really good as well. Okay, so we'll begin from the most distal part of the leg, and then move our way up to the hip, and then we'll jump to the over extremity, or the arm, also known as the arm, and go from the distal part there up to the proximal part, and then we'll do back, and at the very end we'll do children as well, because for many emergency physicians, we will see children, especially in the minor trauma section, where the medical pediatric physicians of Scandinavia usually haven't taken over or have never had a tradition of practicing in that area. So usually the surgical specialties when it comes to kids are either belongs to the surgery specialties or emergency medicine in general. So we need to know that stuff as well. Okay, but beginning with the ankle. So I'll start each of these with a small beginning with just a little bit of anatomy. So we know that the ankle is right here, and the ankle and the foot, I should say, as well. I'm going to go through a bit of the foot as well, and we have the fibula here, and you have the tibia, the two bones of the lower legs, articulating with the talus, and the talus articulates with the calcaneus, and then you have this like the midfoot joints, the midfoot bones. Where amongst other the os naviculara is important, the boat bone, because it's going to be one of the bones that we need to push when we are doing the auto ankle rules. And then we have the metatarsus, and then we have the phalanges. Just looking at the bone structure, it's important to notice that these two bones, the calcaneus and the talus, are very badly perfused. So if they break, depending on where they break and so on, but they're in general badly perfused, and badly perfused bones, just as cartilage or discs or whatever badly perfused area we might have in the body, they heal really badly. So that's important to to think about when we have fractures there. I believe that the calcaneus sometimes can be handled conservatively, but in general they usually have to be handled surgically, at least if they're big fractures. Also, with these areas, there are it's important to notice that almost all of the weight of the body is going through this joint. All of the weight of the body is going through this joint. So if you get problems with this joint, arthrosis is a big problem. So the foot is really important. And we'll see that there's at least one medical condition, diabetes, that is really important when it comes to the foot, because you can get these Charcot feet for somewhat unknown reasons. The foot of the diabetic with time can just collapse and also create some kind of some specific infections like plantar abscesses that we need to be aware of. Okay. The foot also contains a lot of these ligaments, and this is a I think I sorry, I think I said it. This was the tibia and this was the fibula. So we're looking at it immediately. I'm not saying we shouldn't know all of these ligaments at all, but at least we should know that one of the ligaments here, the deltoid ligament, goes and like stabilize a lot of the medial aspect of the foot here, and it goes to a lot of these bones. So if there's anything happening on the medial side with pain, then it's usually something bad. It's a red flag. Having pain, like having severe pain on the medial aspect of the foot, is very bad. And even though the odds of an angle rule will tell you to do an angle X-ray when we have medial pain on the medial malleoli, then as we will talk about, we also need to consider and probably do an X-ray of the proximal tibia and fibula, especially fibula, because you might have a Mason-nerve fracture. Okay. Here's the X-ray part of that, and here we have the navicular, the midfoot, and the cuneiform bones. And here you have the fifth metatarsus, which is important because that's one of the bones you have to push in the odds of angle rule, and it's also a bone that breaks. And depending on where it breaks, it has different treatments. Okay. We talk about Lisfranc's joints, and we'll come to that. But Lisfranc's joints is right here, and it can give the patient severe problems if we don't catch a Lisfranc injury. Okay. Here I'll just give you a few pearls, and we'll come back to some of the pearls later on. But some of the pearls here are that, well, external rotation injuries. Again, patients can't always say what kind of mechanism they had, but if they do say that their foot would externally rotate, because usually what you do when you have an ankle injury or ankle sprain, you will internally rotate, you will supinate your foot. But if they're externally rotating the foot, then that is what Arun Sayal would call the thunderclap headache of the foot, meaning that there's a broad differential of don't miss diagnoses that we'll get into that have this kind of mechanism as the cause. And another red flag is also that if they cannot weight bear, and it's okay to stumble, but if you cannot weight bear at all, then that's a red flag as well, especially if you couldn't do it in the emergency department and in the beginning. So again, it's just if this is part of the external rotation, because if you're sore, if you're like isolated sore in the medial aspect of the ankle, like over the medial malleoli, or if you're loose, it's hard to test stability because it's usually painful. But if you have a suspicion that any part of the deltoid ligament is off, then usually it's a bigger injury, and we have to examine quite quite thoroughly. And as a rule of thumb, if if they are hurting medially, then usually something more is happening, and that something more might be a mesonerve fracture proximally. So it's okay to want to order more X-rays on these kind of patients. And I forgot to say before, if you do, once you have a fracture in any of these middle foot areas, this is an area where CT scans usually needs to be applied afterwards as well, especially with talus fractures or I think, yeah, especially with talus fractures, because usually we'll talk about a child fracture called a tulu fracture, and when that is broken, usually we will under-evaluate how displaced it is on the mirror X-ray, and usually CTs are good for that. But that's getting ahead of the game as well. All right, so then as well, some other pearls here is falls from heights. If there's a fall from height, like someone falling from a ladder, or more severe, someone jumping out of the building, you should always think of the calcaneus injury. But when you think of the calcaneus injury, you also have to think about they will usually be in severe pain, and they will be distracted from a potential injury, like the force going up all the way through their body and up into the vertebrae. So you always have to check their neurology. You have to do that anyway, but there's a high pretest probability, or somewhat high pretest probability, of a vertebral fracture with these kind of actual forces going all the way up through the bone and through to the back. So calcaneal fractures from with high axial load, you have to think about vertebral fractures as well. Then another pearl is like the auto angle rule is not the only exam that you should do. It's important, and it's a good tool to know which ones don't need an X-ray, but you really need to know its limitations, and you need to examine the patient beyond that kind. You have to push on the other bones as well, and you have to test push on other stuff as well, and you need to know like when to order anything else, like with medial pain. That means more than if you're just sore laterally. You also need to take the mechanism into account, and so on and so forth. Just saying that this is a good tool, but it's not everything. And we talked about the CT needing for CT. And in general, if these patients are stable and they can move, then they should move. And we talked about not immobilizing patients in more than need be. Okay. And here's another picture of it, and here you have all the names of the middle foot. I don't think it's important to know all of the names, but some of the names, especially the navicular and maybe the cuneiform, are some of the bones that we will go through. Some of the other bones, like these midfoot fracture, is really rare to have a midfoot fracture. So if you have that, then you have to ask your orthopedic surgeon usually how to handle them, and you need to think about, well, how did that happen, and are there any other fractures related to it? So as we talked about the Big 10 fractures, the reason why they are the Big 10, that's because the mechanisms that are the reason for why we've fallen that way is like it's evolutionary somewhat. we usually break these bones because we usually fall in a certain way, and we usually with age get osteoporotic, and that's why these bones breaks when we foosh instead of other bones. So that's why there's some kind of like mechanical logic to when bones break. And if you've broken a strange bone, then you have to then usually there must be some kind of strange reason why. Not necessarily, but oftentimes. And again, this comes back when you have pediatric trauma. It's really important to kind of, if it doesn't fit the history with the amount of fracture or the strangeness of that fracture, then you have to be aware of it might be a non-accidental injury. Also, if you have a young person, like maybe a 45-year-old, a 50-year-old who gets a hip fracture from a fall, then you have to think about osteoporosis. And we have several of these osteoporotic fractures that we also have to think about. Like if that fractures, then we probably should think about working up the patient for osteoporosis as well. Like back fractures, I think it's distal radial fractures. I think it's the proximal humerus fractures as well. And the hip fractures. I might be one or two more, and I don't know that there is a systematic way in clinics to just order osteoporotic workup on them, but I think we should tell the primary care physician taking care of the patient afterwards to consider working them up for osteoporosis if they have these kind of fractures, especially at a young age. But depends on local guidelines and so on. Okay, here's the surface anatomy of my good friend Emilia's foot, and here we have the lateral malleoli. We have the base of the fifth metatarsals, and we have the os navicular here. If you want to check the pulse, usually the anterior dorsalis pedis is here, and you have your anterior tibialis posterior over here on the medial side. And here you have the medial malleoli. And it's important that when you examine the entire foot that you also squeeze on the leg way up above. If it hurts distally, then you have to think about the syndesmosis injury. If it hurts proximally, then you have to think about the mesonerve fracture, depending on what kind of mechanism of injury and where it hurts in other places and so on. Okay. Yeah, here's the medial malleoli, and here's the where you have to squeeze further up. Okay, so going through the scared off mnemonic for the ankle. So infectious wise, well, gout versus septic arthritis is usually something that we have to think about. Gout is much more usual, but septic arthritis can happen here. You also have to think about the diabetic foot and the infections involved with that, especially plantar abscesses. Compartment syndrome is common in this area, at least in the lower leg. Non-accidental injuries, not necessarily more common here. The X-ray read wrong or referred pain, not that common here. The dislocation, yes, we have to know about the dislocation because if the skin is tending, then it's really important for us to fix it, as we talked about earlier. Occult fractures, occult soft tissue injury that needs to be, operative soft tissue injury would be Achilles tendon rupture. We'll talk a bit about that, but also somewhat gastrocnemius. It's usually not a non-operative thing, but the EMKs is usually has taken that into their lectures as well. And then you have your fractures, the fractures that are often missed or are occult, because the X-ray is really hard to interpret. That would be Lisfranc's fracture, the spectrum of Lisfranc's fractures. You have the Tillou fractures. It's more like a don't miss that. You have something called snowboarder's fracture, which is also a lateral talus fracture. The Tillou is a distal tibial, I think, physis fracture. We'll go back to that. Then you have your mesonerve, which is the upper third of your fibula that is broken, and that's an operative fracture. And then the Dupuytren's is the middle third of the fibula, and this happens, as I said, usually when they have medial pain in their ankle. And then you have a intraosseous ligament rupture. And this is also a injury that is you need to be aware of. And this is where when you squeeze the leg high up, the lower leg high up, then it'll hurt distally. There are other signs we'll go through as well. And you have your calcaneal fracture that you shouldn't miss either. Of course, again, there are other fractures that you shouldn't miss, but these are just like high risk and usually operative that should be caught. The others, well, if you miss them, oftentimes either they're really clear on X-ray, or otherwise it's not good to miss them, but it's not catastrophic. Many of these are more like catastrophic or at the catastrophic spectrum if you miss them, because they are either operative or will make the patient have severe problems if they are not caught. And you have your neurovasculature, and this is important, of course, always in this area as well. And here on this green page we have some more pearls, and so the thing is, it's these pearls are somewhat from the FOAMed literature as well, and from experience, and so a few more pearls is that, well, it's not rare that there's more than one fracture if you have one of these high probability injuries like a external rotation. We also already been through that, but it's important to go through the examination systematically. The mechanism is very important here, actually, more so than maybe in other joints, and trying to tease that out from the patient is important without leading them to some conclusion that they can't remember, of course. So it's important to know what kind of direction the foot turned, the height of the fall, and so on. So we've been through that. All right. So there are certain areas of there are certain patient groups that are important to know about. I heard the patients with a high risk of sensory injury, like diabetes, recent surgery, and chronic alcoholism. These patients we have to be especially aware of, because they might heal in a bad way, or they might not comply with the guide given. And surgical, like the diabetic and the chronic alcoholic will have often have polyneuropathy beginning in the legs, right? So and vascular injury oftentimes as well. So it's really important to take that into account. Then just a few examination pearls is like, if you're hurting on your anterior part of your tibia, then you have to think about the syndesmosis injury. The medial aspect, we went through that, of the medial ankle. We went through that. The talus. Here, I think it's Arun Sayal calls it the ankle's scaphoid fracture, and you need to, as we talked about, it's and the reason why it's the scaphoid of the ankle is, well, you need to somewhat do a CT scan if you think there's something wrong with it, and it heals poorly as the scaphoid fracture as well. So, all right. Then we have to do we talked about the squeeze test. We'll go through that in a little while. The squeeze test of the lower leg, and also angle rule is not everything. Yeah. All right. So the ultimate angle rule, I think it was, of course, like all the rules or tools created by Ian Steele and his research group in Canada. They're really well researched, but they're usually quite low specific and very high sensitive, because they created these tools as a mean of reducing X-ray utilization, and so it's very much from a public health economic perspective that they've done these. And we always have to consider these rules or tools in the context that they were tested. And a lot of, like, at least couple of years ago, we weren't so similar to the North American way of doing emergency medicine. And if you do an X-ray on everyone, well, then any kind of tool that can reduce that kind of usage is really important. But if the Scandinavian standard was different than that, which at least has been before, maybe not in the angle area, but in other areas where they do these rules on tools to rule out without an X-ray, well, then we probably can't apply them and shouldn't apply them as much as they are being applied. But as our societies are becoming more similar, or the Western medicine, North American westernized medicine kind of way of doing medicine is spreading across Europe, and we're becoming the same, then we probably we might be able to use them. But yeah, so there's always that risk with these tools. Okay, so it's actually a two-part rule, this one. So there's the foot rule, and there's the midfoot rule, and then there's the ankle rule. I think it has a sensitivity of around 9500% and a specificity of maybe 30 to 50%. Okay, meaning that if it catches almost all of the fractures that are important, but if in the ankle or the midfoot, but you will do a lot of X-rays, depending on where your baseline was before you used this. Okay, so let's just go through the ankle one. So bone tenderness in the distal part of the posterior edge of the fibula, and then 6 centimeters up, or the tip of the medial malleoli, or bone tenderness of the edge of the fibula, or tip of the lateral malleoli, and unable to weight bear immediately and in the department for 4 steps. And it's okay to stumble, but you should be able to like bear your own weight somewhat. Okay, so that if they have positive of any of those, then they have to do an X-ray of the ankle. And if they're I would say you should, yeah, and then you have the midfoot, bone tenderness at the base of the 5th metatarsal bone, as we showed on the surface anatomy area pictures, and then bone tenderness on the os navicular, and again unable to weight bear. If they have one of the if they have one of these, then they should get a X-ray. And it's important to know that, well, there are limitations if you have reason to think that there's a distraction injury, or they're intoxicated, or they have poor sensation in the legs, that they might not feel the pain, or nuances of small pain stimuli. Then it's, or it's really, really swollen, like obviously fractured, then you shouldn't rule it out either. Something that diminishes the way the patient feel in general. Okay. It can be applied for children, but it's not tested specifically for children that much. So you should be more aware that there might be false interpretations there. Okay, and this is from EM3. It's a really good format channel, so check that out as well. Okay, so that's the out of angle rule. So when we examine the foot, we do the inspection and see, especially, are there tending, are there hematoma, especially hematomas underneath the foot. That's for the Lisfranc's fractures. Are they swelling, and so on. And then we do the palpation. We touch the patient, and we can do it indirectly first, try to actually press the foot and the ankle and see if it hurts and where it hurts. And then we can do the out of angle places, and then you can palpate the rest of the foot. That's usually how I do it. And then you apply this squeeze, the squeeze test on the leg. And bear in mind that anecdotally, I've heard that the squeeze test is not 100% sensitive for the muscle nerve fractures. So you might have a false negative even though they have a fracture. So if they have a high precise probability injury like external rotation, then no matter what the squeeze test says, then probably you should do an X-ray of the fibula. At least that's my logic from from what I can gather. But please tell me if you think otherwise in the comments. All right, so so that's kind of the palpation part of this. You can do a stability test as well, but that's usually really like where you hold the foot and then you try to push in this direction and in the lateral medial direction as well. But usually it hurts too much to do that, and it's something that's done on a later in a later time. All right. The foot is a complex combination of different joints that like functionally it works as a flexion extension and an eversion inversion or supination pronation joint, but like the articulation happens in a lot of these joints. It's not just between two joints. It's more complex than that, and that's why the foot is like, if it's broken, there's a lot of problems there if it breaks, because the normal way that the foot works is quite complex, as I understand it. But we test the dorsiflexion and the plantar flexion. We test the inversion and eversion, and this was really important, especially if you have a drop foot. And then this test is really important, as we talked about earlier, because then you can differentiate an L5 from a peroneal injury. Okay. Here's another surface look at the foot, and here you can see the different joints. And here's the Lisfranc joints, and just to show you, like, you need to know a lot of anatomy and you need to know where it is on the foot. But there are specific pieces of anatomy that are more important than others. And I think we highlighted that already. This picture I borrowed from the course that I just attended. And then, of course, moving the patient around, like, can they move? Can they stand on are they standing on their toes? Can they stand on their toes? Do they prefer to stand on their toes? If you have a Lisfranc injury, like you have actual compression of this area where it breaks here, and it's really painful to push up here. So it's really important to know what kind of movements hurts and where does it hurt when you move that foot. So you would expect it's very much like neurology. Like if you had an actual compression here, like with a Lisfranc injury where you like step on you bear weight, you're injured when you're like standing on a tiptoe. You push a lot of weight on your foot when you're standing on tiptoes, and you might break here. And if you're broken here, then you really don't want to like dorsiflex your foot. So there are different. You really need to think about what kind of injury might have happened and where they are hurting the most when you're moving the foot around. Okay. All right, so let's go to the first don't miss diagnosis here, the isolated syndesmosis injury, or what is also called the high angle sprain, because the mechanism of this is usually that you do kind of the same motion or mechanism as you would with some angle sprains, but you're wearing a high boot so that the stability of the foot and ankle is better, and so the break happens more proximal, as I understand it at least. So usually these are injuries where you, like any other ankle injuries, where you have some kind of, usually this is usually external rotation and dorsiflexion in a high boot, like hockey or snowboarding. And usually when they come to your clinic, they will have anterior angle pain. So when you're palpating the anterior of the tibia and down towards the ankle, it will hurt. and usually they will not dorsiflex, much like the Lisfranc's injury as well. They will not want to dorsiflex. They want to toe walk. And what you do is, well, if you observe that they have this kind of special toe walking and they really refuse to dorsiflex, or if you dorsiflex it hurts a lot and it hurts a lot anteriorly, then you have a high suspicion, especially with the kind of injury with external rotation in a boot, playing some sport with a boot on. Then there are certain tests that are quite specific but not very sensitive, meaning that if they're negative, you cannot rule it out. But if they're positive, then it's probably it. One of those tests is the squeeze test that I talked about earlier. So if you squeeze around mid-calf level, then you will, like the squeeze test is done for two reasons, right? So there's a squeeze test where they hurt distally. This is where it might be a syndesmosis injury, and there's a squeeze test where they hurt proximally. Again, that might be a Maisonneuve or a Dupont-Chance fracture. But I'll remind you again that this squeeze test, I guess, with this Maisonneuve as well, is a very specific but not sensitive test. So if it's negative, you still have to do the X-ray if they have medial pain with the Maisonneuve. All right. And then you can do something called the external rotation test. And I've never done this myself before, but there are videos on OrthoBullets if you want to check that out. If you search for syndesmosis injury. In general, all these cases that I go through, please check the OrthoBullets post on them, because that's much more detailed if you want to find out more in detail information. Okay. So you'll do an X-ray, and it's really important here that we get a Mortise view of the angle, as well as the usual AP view and lateral view, and it can be quite subtle. So in the next slide we'll go through some of these changes that you might find. The treatment for this is a non-weight bearing solution, and depends on what kind of local guidelines, but they shouldn't weight bear on this, because then they'll just split the syndesmosis. And this is, I think OrthoBullets says like it's a rule of thumb is that it takes double as long as a ankle sprain would, and they can be quite complex. Sometimes they need operation. Especially if they have broken something along with their syndesmosis. Because remember, this is one of these vanillekranz or circular areas of the body. So if it breaks one place, it might have broken other places. So you should be aware of that. Okay. Just wanted to share with you one of these things. Now we're talking about ankle injuries. If you have your ankle, it's often described as a circle. This as well, and the stuff that is holding together the ankle joint is, of course, the bony structures like fibula, tibia, and talus, and then you have the lateral ligaments. I think one of them, the most important, was called ATFL. And then you have the medial ligament, the most important being deltoid ligament, and you have the syndesmosis. And if you have a break anywhere along this line, usually you can have, as opposed to the other circular things I've talked about, like the forearm or the lower leg, usually here you can have one break. And we'll get back to when one break might induce a operative treatment because it breaks several places, but usually you can have one break. For instance, you can have your lateral ligament break off in an avulsion, what you call a Weber Weber A down here, and then you don't have to operate on it because it didn't break anywhere else. So, but a lot of people find it helpful to think of this as a circle with 3 ligaments and 3 bones. Okay. And the last link that I just skipped was Andy Neill it was a link that I forgot to mention during the anatomy part. And Andy Neill is an emergency physician, has a homepage called Emergency Medicine Ireland, and has talked on SMAC and has these great anatomy videos with very emergency physician styled anatomy pearls. And I strongly encourage you to check out his videos. They're a bit old now. He hasn't produced in a couple of years, but they're really, really good. And if you want tips on anatomy in a way better way, in a more concise way than I'm doing, then please check his homepage out in the link that I just skipped over. Okay, so here's the x-rays of the syndesmosis. And if you have your, usually that you'll have some more clear space here between, they will overlap in a way that usually they shouldn't. And also you will find that that medially, you might find that medially there's more clear space, more than the 4 millimeters that are allowed here. And usually, so first of all, there's a on the APU, you might find that these are not overlapping. There's like a clear space here, and this might be more accentuated in the Mortise view, where it normally should be below 5 millimeters, but it might be more than that when you have a syndesmosis injury. And then the medial aspect might be there might be a bigger gap here in the medial aspect. And here you see an example of the clear space and overlap. Okay, on to the next fracture. This is what you call also a snowboarder's fracture, I guess. Also wearing a boot. Usually this is also external rotation, but this is a fracture where it breaks in the talus area, lateral talus area. And this is one of those where, well, the mechanism is usually like external rotation with dorsiflexion and axial load when you land. And I guess usually the common history, according to EM cases, I've never seen one of these though, is that they come in after 1 week and are still in pain. It seems like they had an injury, like a sprain, but it keeps hurting, and then they come in to check up, and these injuries, again, this is the talus needs some kind of CT to see the extent of the fracture, and this might also be one of those where you wanted to do a CT if you have a fracture of the talus, and or ask your consultant for treatment. In a lot of these diagnoses, I won't go through the treatment because it varies with local guidelines. Some of these fractures are not like don't miss, but they're usually oftentimes commonly missed as well. So it's a mixture of commonly missed and don't miss fractures. These. Okay, then on to the Tillot fracture, and the Tillot fracture could be thought of in a lot of ways as the syndesmosis injury of the children, mostly because it's the same mechanism that goes to do it. But this time it's a fracture of your tibia, and we'll go through it in the child lecture. But the way this part of the bone, this part of the bone, the epiphysis, the way it ossifies, is like this part is soft and the other one is quite hard, and that's why it ossifies in this age 12 to 15, and that's why like in this age group you will get like this break before it's totally ossified. So we have this kind of sugar cube break that you can see here, would be named as Solder-Harris 3, but it's something that where you also need to do a CT scan to actually look at the extent of the injury, I think, and usually it won't happen above the 15-year age range, because then the entire thing is ossified. Okay. And then you have the gastrocnemius rupture. And the reason why I guess I and EM cases have this on their list of don't miss or commonly missed is that it's usually misdiagnosed as a DVT in 30%. And the mechanism is usually someone like a weekend hero, or what you might call them, who maybe doesn't train that much, but now they decided that they want to run up hills, where you really have to put your gastrocnemius under tension, and then you like overdo it, and then you will you might break the gastrocnemius, and usually they will just feel a bit of swelling. That's why or maybe tension, and that's why the DVT is usually what a lot of people think that it might be. And I mean, there are certain signs according to EM cases where you could distinguish between the DVT and gastrocnemius without using ultrasound. I guess this is one of the reasons why you might use ultrasound to just check for DVT here. But they're more swollen medially, not like globally, or not circumferentially like a DVT often would be. You might be able to feel the gap between in the broken muscle and the tendon, and there might be also ecchymosis. You want to do what is called a calf raise test, where you try to make them stand on their tiptoes. But usually, so you let the patient stand on a box or some sort, and then you on the tip of that box they have to stand, and they have to like raise their calf, or they have to stand on tiptoes there. And if they cannot do that, or it hurts in the gastrocnemic muscle, then you have a clinical diagnosis. And I guess like this is not a don't miss, because the treatment is just RICE, or and it's important that the R in RICE is not rest. It's restricted movement, so it depends on how much it hurts. It's really important. They should not just lay down and rest. They should move as they usually would. And then it's the rest of ICE has become increasingly controversial the last couple of years, and I'm not sure that I haven't heard too many orthopedic surgeons mention RICE recently, but some sort of like move as much as the injury allows is what I understand the treatment is for gastrocnemius rupture. Okay. Then you have Achilles tendon rupture, and I actually not done much on this. Usually, it's like in Denmark, it's usually a badminton injury, or like where you really have to like jump again, like, or running uphill, I guess, as well. It's important to know that like these tendon ruptures might be associated with ciprofloxacin treatment. There's at least a risk with ciprofloxacin. You usually do your Thompson's test to see if there's a lack. So you lie the patient on the belly and check. There's also, I can't remember the name of it, but there's also a test where you let your patient lie flat on the belly, and then you flex their legs and see if the angle, the tension is like if it's lack. But I forget the name of it. There are two tests, the Thompson test and the other test, and then you might be able to feel the gap. You should probably not use ultrasound. Sensitivity and specificity is quite bad for what I understand, and there's high integrated reliability. So usually the recommendation is that you should not use ultrasound for this. Okay. Then we go on to the Maisonneuve or Dupuytren's fracture. The difference, as I mentioned, between these two is that you have the Maisonneuve is the fibular fracture in the upper third of the fibula, and the Dupuytren's is the middle third of the fibula. These are unstable fractures, and that's why we often we talk so much about them, because they need to be operated on usually. The mechanism again here is usually, again, it's the medial aspect of the ankle that is being that's being that is problematic, because there's been a lot of force on it, and so usually it's an external rotation, and if they, as I said, if they hurt a lot medially, then you should always think of doing a X-ray of the proximal part of the fibula. Even though the squeeze test might be negative because it's not sensitive enough, so you should do that. Not too much more to say about that, I think. Then we go on to the calcaneus fracture, and I always write calcaneus and vertebrae fracture because, as I mentioned before, it's really important to rule out a vertebrae fracture if you have someone who has an axial load injury, jumping from a high, like jumping or falling from height down on their feet, because the force will go up through the spine and may break as a vertebrae. Okay, just a bit of epidemiology about this. 10% might develop compartment syndrome, so it's important to think about that, scared of. Then the calcaneus injury is in many ways horrible injury. It's a bad. It heals really bad, and around 1 in 5 are not fully functional after 3 years. As I said, in the early 20th century, this doctor said that the patient with a calcaneal fracture is done with their working life, or at least say 1916 kind of working life, so like rough labor, because it takes a long time to heal, and the function might not be perfect. And if it has a big fracture, what you call it, I think it's called duck beak fracture, where it's really opened up, not like this, but even more, then at least the course director said that that's really one of the don't miss fractures that we should call them during the nighttime to fix almost. These are usually done in university hospitals in Sweden, as I was told, but that like really open fracture needs to be operated on right away. So that's why that kind of fracture is something that every hospital should be able to treat, as we were told, I think. Okay. And it's as much as 50% of the calcaneal fractures who will have a spinal fracture, and 10% of those spinal fractures will be with medullary injury. But of course, it depends on how far they jumped and so on. There's something called a Harris view. If it's subtle, if it's X-ray is negative, but you have a clinical suspicion, high pretest probability, you might order something called a Harris view. And I have no idea about how you measure these angles, but there's something called Bohler angles, BOHLER, that are something that can show some of the very nuanced breaks in the calcaneal area. You might want to check that out. All right. Here's this duck beak kind of open, like an open book. This is a very emergent operation, as I understand it. Though, as I understand it, the Danish orthopedic surgeon guideline said that the rest of these calcaneal fractures are usually not done operatively. I guess it's a more complex decision, but these really open ones, they probably should be operated on right away, as I understand it. Beak type calcaneal fracture. Okay. Then we go on to the infamous Lisfranc's injury, and I think I mentioned that if you miss it, you will get arthrosis. But I think there's definitely a spectrum of functionality that can occur depending on the spectrum of Lisfranc injury. Because here's the spectrum of Lisfranc's injuries. The Lisfranc injury happens here at the Lisfranc joint, between the in this area between the first and second metatarsus. And you see, like, it's splays open here, and if it's more like first it's just a little bit really nuanced, and then it can open a lot, and you might have small avulsion fractures as well. And this injury can become a really functional impairment for people if it's not treated decently. So that's why it's something that has come up a lot in the FOAMed literature for the last couple of years. This is something that we should not miss, and especially because it's quite easy to miss this. So we need to go a bit into detail about the how you get this injury. So the mechanism is usually someone landing like this. So it might be an elderly male or female stepping over the last step on the stairs and then trying to parry the fall by doing that, or like hitting the ground awkwardly in this kind of ballet kind of foot volar flexion. And so the forearm goes up here and breaks around here. Okay. What they will usually do, I said volar flex or plantar flexion, and there might again be external rotation. Again, all of these, the previous ones I've talked about, is almost all of them have been external rotation, except the calcaneal fracture. So external rotation is really we need to think about a lot of these bad fractures when we hear external rotation. Okay. All right, so these are also unable to weight bear. Like the syndesmosis injury, they will usually want to weight bear in this position, because if it dorsiflex, then it'll hurt like hell. They classically might get this midfoot hematoma, but not always. Again, these are not sensitive things, but it's like all the small data points here that should point us to think about this injury. And if it's obvious, it's obvious. But if it's just a minor one, then it's probably a harder catch. I've never caught any of these. I've done a few imaging studies for these, but I've never caught any of these. The thing is, again, you should do an X-ray, and optimally you should do an X-ray, weight-bearing X-ray. But usually they don't want to weight bear, so either you have to tranquilize them in some way, or they have to be followed up and do these tests for weight bearing to confirm the diagnosis, and then you treat it in the emergency department as a Lisfranc, and then you have to follow them up to confirm the diagnoses. Again, both CT. This is one where you want to consider CT, but what you also want to do just right away is just to get an oblique view of the foot, and sometimes you get that, and sometimes you don't in a standard package. So you should think of getting a oblique view of the foot for these. Yeah. And the treatment, again, follow local guidelines. I'm pretty sure it's non-weight bearing for these, but check out the local guidelines for that. All right, so now we'll move on from the commonly missed and commonly misdiagnosed and don't miss diagnosis to the more common ankle fractures as well. So we get the entire spectrum here. So we talked about this circle here where you have the ligaments and the bones, and the ankle in general. As opposed to the other like circular areas in the body that I talked about, then one break here might be all right. Two breaks are unstable. Okay, so and depending where it breaks and so on. There's this Danish physician, orthopedic surgeon that we were usually told about during our orthopedic course on when I attended university, because he or they made these. I think it's just one person who made this mechanistic kind of fracture classification called Lauge-Hansen, and we were told about how he, whenever there was a corpse that he could do this on, he was like he would be woken up during nighttime, and he would drive in or get into the hospital and do these tests on them. And Lauge-Hansen shows a lot about how the angle, or shows almost everything about, I think, how the angle breaks. But it's not it's quite, there are certain YouTube videos that might explain in a good way, but for me, it's at least, it's a quite complex classification, and it doesn't really do much for, as I talked about, like these classification systems are really descriptive, really good descriptive, and really good to communicate what's happening and to understand, but they don't translate to whether or not we should treat a Lauge-Hansen type this and type that with that specific kind of treatment. In at least outside of Denmark, maybe in Denmark now as well. What I'm usually told is that we use the Weber classification for the at least the lateral ankle fractures, and I've not heard too many other classifications that we should use. All right. And the thing about Lauge-Hansen is that the angle breaks in specific ways, right? So if it externally rotates, then it'll break first one place, then another place, and then that's the entire thing about it. So if you wanted to know where the angle breaks with different positioning and different mechanisms, then the Lauge-Hansen is the one that you need to check out the YouTube videos for. Okay. So the exception with the one break, that one break is stable, is our Weber's C and an incongruent B, which we'll go through, and also a anterior syndesmosis might be unstable sometimes as well. Okay. So there's this thing that I've talked a little bit about what you call congruency. When we talk about congruency in this Mason view of the ankle, it is so that you can follow a line that is equally far apart here. I think it should not be above 4 millimeters. I think this is, but part of that is also just looking at what is the layout of this, and are there any incongruencies there. So this would be a congruent joint. And again, it all depends on these ligaments, the ring structure that we talked about. So if one of them is off, then you have to think of stability, instability, and especially depending on the mechanism. If you do get the mechanism and let's say you have a person internally rotating so that it would be off here, but you see a fracture here, then you should think about that's where the Lauge-Hansen might come into. It's like how can you break only here? There should be a break also maybe on the backside. It might be a trimalleolar fracture then. Okay. Yeah, and this is what you have to measure the congruency. Okay. Yeah, around 4 to 5 millimeters immediately. Okay, so the common fractures here are bi and trimalleolar, and the lateral malleolar fractures, the metatarses, and then the phalanges. The bimalleolars are if you have breaks in both of the malleolars. The trimalleolar is if you also have a break on the posterior part of the tibia as well. And sometimes it's really important to look at the lateral picture there. The metatarsus 5 is important because usually you'll just break down here, but you might sometimes break here, and I think that would be an operative fracture, that what you call Jones fracture. So it really depends on on which part of the the fifth metatarsus that breaks. It really depends on where it breaks, what kind of operation it will be, and whether or not it will be an operation. There's another thing about these metatarses, no matter whether it's the fifth or whichever one it is, if it is if it's angulated towards the sole of the foot, so that it's like these are. I should have done a lateral picture here, but there's a lateral picture here. So if these are usually straight, but if one of them is angulated down towards the ground, like so it's like almost like when you're walking, it's pushing into the ground, then it's really important that that should be fixed operatively, usually, because as we were told, the distal part of the metatarsus are like small hammers. When you look at it, like if you have a bone model, you can see it, and these will just like hammer through your sole, and then make a terrible ulcer and injury. So it's really important, if they're angulated towards that towards the sole, they should probably be operated on. Okay. The phalanges and the metatarses are usually non-operative, like as a rule, but you have this frank joint, and you have the Jones fracture, and you have the plantar. If it's angulated plantarly, then usually they have to be operated on. But in general, usually they don't have to be operated on otherwise. But check your local guidelines. Okay, nuances on the lateral fracture, because this is one of the most, like one of the top 10 fractures, so it's worth going a bit further into detail with that. So you have your Weber's classification with this. The Weber classification is that you have like 3 kinds of fractures. You have your A, you have your B, and you have your C, depending on how high on the fibula it's broken. And the A is usually an avulsion, like the ligaments have been stronger than the bone. That's really common. It's usually or it's always stable. You should just weight bear and depending on your pain level. And the C is always I think always operative. So you should always just like that's just operation. So no operation. The B is the one that is a bit tricky. So we'll go a bit through that. Yeah, the C is usually broken in other places as well, so it's unstable usually. The B it depends on the congruency, as we just talked about. So if it's a congruent, like meaning that the distance in this joint, this multi-joint here, is below 4 millimeters, and you don't see any other fractures, then it's interpreted as a congruent, stable one, and then it's usually not something that you have to operate on. But if it's incongruent, then it's something that's often operated on. There's this rule of thumb that if a patient comes into your clinic after a couple of days or maybe weeks having walked on one of these, and you see a fracture that should be unstable, then I know some orthopedic surgeons will tell you that this is it's proven to be stable then. So they will treat it as a stable fracture, and I've been, I've seen that a few times. So, and I'm sure they're right. I don't know how much time it takes for a fracture to present itself as stable. I guess it depends on the risk of it gliding, and if it's high risk, it should glide right away. If it's low risk, maybe it takes more force, and it should maybe be followed up at least with X-rays. I don't know, depends on. But if a patient has been able to walk around on a leg with what should be on X-ray or classification systems an unstable fracture, and it seems to have been stable anyway, then oftentimes it's usually treated as a stable fracture. All right. Small like details again here. The diabetics should usually, this is a cast for 6 weeks, but the diabetics has 8 to 10 weeks usually. There's one exception here as well, and I think I put it wrong here, but if it's if there is a congruent, but it's congruently wide, like it's widened everywhere. There's a max to how wide it is allowed to be everywhere, even though it's not asymmetrical. Then there is a number usually in the guidelines of how long. I'm not sure it's 2. I don't think it's 2 because below 4 was the how much it should be in one place. But but you should it should be congruently wide, and it shouldn't be congruently widened too much either. Okay. All right. Then on to the non-common and non like bad fractures like that. These are the more rare fractures. We've already run through the calcaneal fracture. But the talus fracture, again, we talked about it has low blood supply. There is the snowbird fracture that we talked about, but other kinds of fractures there we should treat with respect and do a CT scan because they might be much worse than we think. Navicular and cuneiform are usually quite rare. They usually also need a CT and often need operation. And metatarsus fractures type 1, the first metatarsus sometimes often need an operation as well. So that's another exception to that. Metatarsus don't need operation rule, but these are rare as well. So it's kind of we didn't go through stress fractures, but that's also common in the foot to have like small. I don't have an X-ray over here, but they usually have like these small nicks that are classically stress looking. For someone who's been out in the woods walking in military boots for an hour or a couple of hours every day, that's the common history. Okay, moving on to a new joint, the knee joint. Okay, so the knee joint is placed right here, as you might know, and it consists of it's like the anatomy that we need to know here is you have your femur, you have your tibia, and the tibial plateau, as it's called, and with the immanentia in the middle. It's always hard to know what is medial and what is lateral here, but just the fibula is always lateral, lateralis. So it's lateral here. So this is the lateral plateau, and this is the medial plateau. Okay, and then you have your sesamoid bone, the patella. And well, that's all the bony anatomy, at least, that we need to know about. Then you have some ligaments, and I think I will have a picture of that later on. But just in short, there you have your cruciate ligaments, your anterior cruciate ligament, and your posterior cruciate ligament. And then you have your lateral and your medial and the medial lateral carolateral ligaments. And these are extremely important as opposed to a lot of other joints where the ligaments are not that important. These are often really important and sometimes operative as well. So that's why we need to know about some of them. There's tons of other ligaments again in the knee, and just to mention one of them that might be mentioned sometimes is the ligament going from the patella and keeping that in place. I think it's attached medially, because the patella usually luxates or dislocates laterally. So there's like a ligament going here to the patella, and that might break as well in different places depending on whether you're a child or an adult. Okay. This is my very good friend Emilia's leg, and here we have the surface anatomy. You have your head of your fibula down here. You have your tuberosus tibia, and this is with children having like osgood-Schlatter and all of these knee problems and leg problems. A commonplace for pain in especially in children. You have your patella, and then you have your what we done here is painted very detailed. The quadriceps tendon attaching to the patella, and then the patella attaching to down here the tibia. Because these are important in as we'll talk about in a little while. Here from the side, there is this area where just 1 centimeter, like medially and just 1 centimeter below the patella, the border of the patella, you'll get like a soft spot here, and this is the soft spot that where we want to, if you want to drain, that's at least the medial way. You can go in through other places as well. That's the medial way to go through, as we'll show you in a little while. Okay. And here was a picture of the ligaments, and the patella tendon, the gastrocnemius, the quadriceps tendon, attaching to the big muscle here, the quadriceps. The tuberosus tibia, the head of the fibula, and you have your you have this patellar ligament that breaks when you do at this location. Yeah. And this one breaks medially with children and laterally with adults. Here were the cruciate ligaments, and the lateral ligaments, which are probably the most important for emergency physicians to know about when it comes to ligaments in the leg, in the knee. And here is where the meniscus would be. Those are not too important for the emergency physician. We almost never have to test for these in the emergency department, because usually it's hard to test, and it usually doesn't have a consequence to not pick them up right away unless the knee is locked. But that's the presentation that we need to be aware of. So, all right. And as you can see here, I always think it's hard to know which one goes which way, but the ACL goes from the back and to the front, and the PCL goes from the front to the back. And why are they named the way they are? Well, they just are. But I usually think of it like this: the injuries that are really uncommon, that is the PCL. That's quite uncommon, and the way that you get the PCL injury, you can be by like a motor vehicle accident, where the lower leg is pushed back, and that means like this thing gets tense and that breaks off. That's how I remember it. I'm sure there's lots of other ways to remember it, but you do your mnemonic with it. All right. We go through the scared off mnemonic here again. The infections, well, they are not uncommon. You can have a septic arthritis in your knee. It's a very good place to have it, so to speak, because we can drain it easily there. And the compartment syndromes in the knee area, like the thigh area, maybe it's not unseen, but it's not the common places like the lower leg as we just went through. Non-accidental injuries, we'll go through that later. Referred pain is really common here, because as we talked about, referred pain from the hip in both elderly and children is very common. So when they present with knee pain, but you cannot reproduce the pain at all in the knee when you're examining, but then you have to like always examine the joint below and above, and always examine the entire leg when it's the child, or the entire extremity when it's the child. So, and the red flag there, or the cue there, is that if you have someone saying, "Oh, it's knee pain," but you cannot reproduce any pain, then you should always think of this as referred pain, whether from a medical cause or from a cause proximal joint like the hip. Okay. Then you have the operative soft tissue injuries, and that would be there's a lot of them here. That's why we went through the ligaments. There's the quadriceps or patella tendon rupture. There's the locked knee, usually from an ACL or a meniscus that is locking the knee. And it's important that it's a mechanically locked knee, not a painful locked knee. So you might not want to extend your knee fully if you just have a painful knee. And that's why sometimes it's hard to diagnose in the emergency department. But if you have someone who's not in pain and they have a locked knee because of the mechanism, then it's that. Okay. Of course, you have to drain the knee to be perfectly sure. Because if it's swollen, then they will have an extension defect as well. Okay. Then you have your patella luxation. And the patella luxation is especially important with children because they might, if they have a hemothron, like blood in their knee after a patella luxation, then it's something that needs to get an MRI within 5 to 10 days, depending on local guidelines and so on, because they might have a operative injury in their cartilage. Okay, then you have your ACL. Ruptures, they are not operative usually, but what I didn't put in here actually is, and the reason why is because it's maybe a bit controversial, but the LCL is one of those that we should not miss either, because the LCL, grade 2 or 3, they're graded from 1 to 3. The grade 2 or 3 are usually operative within a few weeks. So it depends on what like your definition of don't miss here again, but those are the ones that should be followed up closely. Okay. Then you have fractures that are usually missed, and that's usually the elderly patient who has a lateral tibial plateau fracture. We'll go through that. And neurovascular, it's really important with the knee dislocation. We'll go through that as well. Okay. There's a bit of injury mechanism here in usually the cruciate ligaments, the ACL. We just went through how to do the PCL. Is usually like a bigger injury, or if the lower leg is being pushed backwards in some way. The ACL injury is like in Denmark is the common handball injury, like the sidestep rotation injury. And the thing is with the ACL, that is it's important to know that they will have swelling right away, because they're intra-articular, as opposed to the meniscus, which will not swell up right away and might not swell up at all. The thing is with these injuries is that they also, if they the patient might feel like, oh, the leg is giving away, they don't trust the leg. That's usually the history that you hear. But these are usually not operative, as our course directors said. Well, there are basket players in the NBA who play without any anterior cruciate ligaments. So usually anterior cruciate ligament injuries are they need to be trained, where you have to train your muscles to stabilize the knee, and then you probably won't feel anything about it, or at least minimally. So I'm sure there are certain sports orthopedic surgeon experts that would disagree. So I'm just saying that it's controversial to operate on, and it's probably the best way to do conservative management and strengthen the leg in the first place. And when that fails, and if that fails, or it's not something that is giving them the function level that they need, then they will consider doing operation. Then meniscus is usually a twist injury, but with age, our meniscus becomes less, I forget the word, it's less gelatinous, it gets more brittle, and so it happens for all of us in some way or the other, just like our discs in our back. That these will degenerate, and then we might have one event where it hurts, and usually nothing is done about it. At least if they're not locking the knee. and it's at least something that we in the emergency department don't need to care too much about, unless the knee is locked. All right. Then there's this thing about if you have a valgus strain, like if you have injury laterally towards medially, then the MCL is strong with children with these kind of injuries, you will usually get an avulsion. With an older patient, usually the ligaments are so weak that he'll just clamp the bone against bone, and then you'll get a lateral tibia fracture. But with the young, usually the MCL will hold, and you'll just get a bit of an MCL injury. Yeah. All right. Let's see. Are there any other things I'm missing here? Nah, that's all right. Okay. There is the thing with if you have an injury, if it's not a twist, or if it's not if it's a direct hit to the knee, then we have the Ottawa ankle rule or the Pittsburgh knee rule to check out. We'll check them out in a little while. We were told at the course that in Sweden, in a lot of places, they would do x-rays on all twist injuries as well, and not just the ones falling on their knees. And their argument was that a lot of these patients do have small avulsion fractures that might change the management of the patient. I'll go through one of the algorithms that they showed us, but it seems like it's an area where when I read the guidelines from Denmark and read the guidelines from Sweden, or the few guidelines I can find in Sweden, because they're usually none like at a national level, then there are discrepancies and in local practice here. So please look out, take this as an inspiration, or take this as, oh, they could do it like this as well, like a kind of inspiration, and then check your local guidelines. Yeah. Okay, the Ottawa knee rule. If you have a patient that is more than 55 years old and they're tender in the patella, or they're tender at the fibula, or they have inability to flex their knee to more than 90 degrees, or they can't weight bear immediately after or at the emergency department, then you have to do an x-ray. That's the Ottawa knee rule. So these are the two areas that you have to push above. And in my opinion, most patients having a fall on their knee usually gets that. It's quite sensitive. In studies, it's around 100%, and it's specific to 54%, something like that. So it's much like the Ottawa ankle rules. So in a place where the baseline of doing X-rays on everyone is quite high, then it would reduce X-rays, but I'm not sure in Scandinavia whether it would or not. You have its contender, the Pittsburgh knee rule, which actually it seems like somewhat better. There are certain comparison studies done in the Netherlands in 2013 that actually show that the Ottawa knee rule had and the Ottawa the Ottawa knee rule here and the Pittsburgh knee rule, they had similar sensitivity. In that study it was 86%. But in terms of specificity, the Pittsburgh knee rule was much better, with a specificity of around 50%, and the Ottawa knee rule all the way down to 25%, making it almost a useless test when you talk about likelihood ratios. Anyway, okay, so just to say that this is usual local guideline about whether or not you should use these tests at all, and this test is not just as the other ankle rule is not a replacement for clinical examination. So this one Pittsburgh knee rule is like fall or a blunt trauma mechanism. If they don't, they shouldn't get a knee X-ray. If they do, well, if they are in this age range, then you do your knee X-ray. If they're not, then depends on whether or not they're able to weight bear. There's no pushing on the knee here. There's no pushing on the patella or the fibula, and I like that because almost all of them are hurting on the patella if they fall on the patella. So, but again, use it with caution. Okay, on to the examination. So when you examine the knee, in general, this is not the thorough orthopedic office kind of examination. We are trying to don't miss things in the emergency department, so our exam is more focused. And with the knee, I remember in some places I worked in Denmark, we would probably do minimally with the knee as long as it wasn't locked. Like the reason why we at all do a knee examination would be to determine whether or not we should do a quick follow-up or not a quick follow-up, because all of these patients are really hard to examine in the emergency department if they come right after the injury, because it hurts, right? But let's go through what at least minimally is expected, I think. Okay, so you do your inspection. When you have the patient in general, it's usually more comfortable for them to have a 20 degrees angulation on their knee, so 20 degrees flexion. So put a small pillow under their knee is a nice way to start the exam. You could then you expect the knee for, is there any swelling especially? And you might do the hydrops test where we try to collect fluid and then push on the patella. I'm sure you know which one I'm talking about. And you do a 360-degree view to see if there's any breaks or any breaks on the skin. You also want to check if there's any obvious like lack. So if any of the ligaments are off, especially if it's the posterior ligament, then you'll see that the lower leg is like is sagging when you're putting the leg on in flexion, and when you're putting the knee on flexion, so the patient's foot on the bed and the knee is in flexed mode. But other than that, that's probably what you would inspect. Then you palpate, and it's important to again palpate all the bones, palpate the ligaments especially, and it's really important to be meticulous about palpating laterally. If they have, if a patient has had lateral to if they had trauma and it's like they're really hurting me laterally, then you should have a high suspicion of the lateral plateau fracture in elderly patients. And the reason why you should have a high suspicion is because it's often missed on X-ray, as we will see, and usually it's an operative management. So the lateral is important. It's also important because the LCL ligament is usually something that we need to be a bit more quick about, as opposed to the MCL. It's not. All right. Then movement. Movement is important, and what you want to test is the stability in all four directions, right? So you have four ligaments. So you will test for anterior posterior, and you will test for lateral medial stability. And this is where this is usually hard because it hurts in the emergency department. But the important thing about these tests is that there's a high inter-rater reliability when you're doing these tests. Like orthopedic surgeons are experts because they know how to feel this, and it's really it's really like the Lachman's test is something that you really need to actually have it feel in your hands, like feel in our normal patients, and like know where you want to keep the leg, and to be able to like actually examine this. And then you have to feel this when you do this jerking, when you do this jerking movement to check the ligament. Like you need to know that you're not just pushing on the muscles, or you have to like when you do it right, you can feel it in your hands, and that kind of feel takes some time to actually learn, and to learn when it's not there. As always, you can always test the patient's opposite side, right? The patient is always, it's nice to have two limbs, so we can always test the opposite side, but it's important to get a feel for these things. There's this rule of thumb that if there's more than 2 injuries, meaning like 3 or more, then you always have to think, if there are more than 3 or more ligaments injuries, then you have to think about this might be at this location, and then you have to think about the vascular stuff, and we'll go through that. Okay, so testing for LCL and MCL, this is where you put the patient's leg in your axilla, so that the angle of the patient's leg is in your axilla. Usually if I'm standing if the patient is lying on the bed, then I'll be standing on the patient's right side if it's their left leg that is hurting, and then I will keep the patient's left foot in my axilla, and then I'll flex the knee just slightly. It shouldn't be flexed too much or too little, so around 10 to 15 centimeters, and then you kind of hold the tibia and the fibula, and then you like try to see if there's gap. You then try to force it medially and laterally. And again, it's a high rate of reliability. You need to test the patient's opposite side and so on. But and we'll go through what you can feel. But in short, there are 3 degrees of ruptures in these ligaments, and the third, like the worst, is just a total gap. The number 1, or so type 1, is just pain, but there's you can feel that there's it doesn't give. And the type 2 or the grade 2 is the one where there's some give and pain, but it doesn't like totally open as a number 3 would. Okay. Then, all right. One other thing about the LCL and MCL I forgot to mention is that usually, like when they break, usually you not get any swelling of the leg, or of the knee, because they're not intra-articular. It's usually only intra-articular problems that will make the leg or the knee swell, right? Of course, you can get bleeding externally, but usually it's in the joint that is swelling. Okay, then you have the ACL. There are the classical Lachman's test. There's a drawer test, but according to EM cases, there's much better sensitivity and specificity, and probably intra-rated reliability with this lever test. So that's the one I would use. And I'll show you with a picture soon. The PCL, that was the sacking knee, and you can measure, I guess, these PCL injuries as well, but usually that's not something that we need to do in the emergency department. Then you have something like the apprehension test. The apprehension test is just like when we come to the shoulder injuries, is like if it's been out of joint, then it will feel really weird or uncomfortable to try to push the patella out of joint, out of articulation again, and that's a positive apprehension test if they really feel that uncomfortability, or you might even feel that it's giving away much more than one side than the other. Then it's important to do a straight leg test, meaning that you make the patient lift their leg straight, and if they can't do that, then you have to consider there might be a quadriceps tendon rupture. because that's the one that would stretch the leg. You also have to think of, like, when you're considering whether, like, when the patient is having a straight leg on the bed, and you're trying to assess for extension deficit, you can put your hand underneath their knee, and if they can touch your hand with the back of their knee, then there's no extension defect. Of course, you have to think about the different sides, opposite sides, and there might be variation, but that's like a rule of thumb. Okay. And it's important when it comes to locked knees, how much extension defect can there be before you say that it's a locked knee. Look at your local guidelines, of course, but in general, you should like see that there's no swelling. You might have to drain the swelling to actually examine this, and maybe you don't do that at your department. Then you have to arrange a follow-up, at least a quick follow-up, to assess whether it's a mechanically locked knee or just painful or swelling caused locked knee. Okay. Yeah. Then there's this thing about laxity and looseness, and I can't remember which one is which, but a lot of you can feel a patient having loose ligaments. That's all right if they don't feel any problems with it. So that's like the looseness and laxity. It depends on whether the patient is bothered by it. So if the patient is bothered by it, then it's just to distinguish between there's subjective and an objective to having a looseness, right? Sometimes the patient feels it, but you don't. Sometimes you feel it, but they don't. And the problem, it's easy when you agree, and it's harder when you disagree. Okay. Here was this the grading of this. So here's someone performing the before mentioned test for this. They do it a bit different technique than I usually do, but you can do it like this as well. There are a number of techniques with this. Do one and learn that one. But here you have your grade 3. That would be for this LCL ligament, where if you could just totally open the leg, there's nothing holding back. And then the one is just, it hurts, but it's totally stable, just as the other knee. And then the grade 2 is like the in between. There's some laxity, but there's an endpoint. Okay. The reason why this is important is these two are operative. This one is not. Yeah. And in Sweden, as I understand it, it would be you have to do it within 3 weeks. We currently don't do knees that much because we have a knee clinic right next door. So that's why I'm not quite sure on how we do it, like how they do it. But in a lot of from the course directors, we were told that this is actually what they would do where they practice. In Denmark, I haven't been able to get a good answer on this. It seems like in the guidelines that I can find, it's not quite clear. It doesn't seem to be as urgent, and therefore might not be something that we need to do in the emergency department. But yeah, follow your local guidelines. Okay, let's move on to the don't miss diagnoses. There are around 7 of them here in the knee. Okay, so just before heading into the differential diagnoses, I just wanted to get this annoying bit of terminology off my chest. Because I don't know about you, but I've always found this hard. That you have in the legs, this position is called valrum, and this one is called the valgum. Usually, or not uncommonly, these terminology from the upper extremity, which the equivalent would be valrus and valgus, is usually translated. So you don't usually use the Latin correct definition here. You usually just say varus. And I think I might have said it wrong during the lecture so far because I'm usually confused by this. I like to say that if force is applied, then it's easier just to call it lateral to medial force instead of, or medial to lateral force, instead of talking about varus or valgus violence. But you'll probably need to know this, and I always have to look it up. So here it is. I guess this angle, when it angles like this outwards, and then then it's the R, or varus, varum, and then if it angles like that and like that, then it's L, valgus or valgum. Yeah. The reason why I brought it up is because the lateral tibial fracture, I think I said it wrong the other times, because here it's, I would say this is this is valgus, the violence of valgum, because it's in the knee. It's medial to lateral violence, meaning that the violence or the force is coming from here. This is medial, this is lateral, so the violence is coming from here towards there. So the lower leg is being turned this way. And what that does is that with young people with strong MCL ligaments, this one will break the MCL, but there won't be any fractures. With as we talked about with children, where the ligaments are stronger than the bone, then the ligament will be intact, but there will be like some kind of avulsion fracture. And in older patients where there's totally laxity of the ligaments, then you'll have this piece of bone meeting this piece of bone, and you'll have a compression fracture here, leading to what you would call a lateral tibial fracture. And the lateral tibial fracture is, I think Aaron Sayal calls it the dark corner of the leg, of the knee, because it's infamous for being missed, this fracture, and it's usually an operative fracture. And when you do a CT scan on it, it usually looks worse than it actually is. But I'll try to give you a few pointers on how to pick it up. And one of them is, if a patient with that kind of violence from here towards here, older patient has pain laterally in the knee, and might have swelling as well, but especially pain laterally, then you should be highly suspicious of this kind of fracture. And you might want to order a CT scan even if the X-ray is negative. Now, on the X-ray, and don't be confused now, here's the fibula, this is the lateral. These are quite obvious. But what you need to know to actually find the most subtle ones is that look at the plateau here. There are a different shape depending on where you are. So, so on the medial aspect, it's like curved, like a wave. Then you have the eminentia, and then usually it has to be straight here. There's a straight line here. The lateral part is straight, and that you can paint these caricatures of the concave medial aspect plateau, medial plateau, the very linear. It doesn't show here because it's fractures, but I'll show you in a bit. The linear lateral plateau, and then the eminentia, which is like an M shape. Okay, so when you look at it from a lateral view, for instance, then you'll see that in a normal knee, they're all in like on top of each other. But if usually with a lateral plateau fracture, then this red line, the lateral aspect, is pushed down. So you'll see this line, and it's subtle still, but that's how to think about it. It'll be pushed down into way below where it should be. That's what you have to look for. All right. So let's see. Here we have the if we paint this thing that I show you, then we have the concave and the line, and here you have them all on top of each other. You have the line, this is the same picture. You have this line here. You have the concavity as well here, and then you have eminentia. Okay. And here there is a disruption of this line. You cannot see this line. It's not a line anymore. And you see the line has been pushed down on the lateral aspect. It's not the most clear picture, but that's what you have to look for. Okay, we move on to the locked knee. And the locked knee is important to catch for emergency physicians because if it's not handled within a certain time frame, within weeks, I believe it is, then, and if they don't get decent rehabilitation, they might end up with permanent restriction of motion in the knee, as I according to EM cases. The usual course of a locked knee is ACL rupture or a buccal meniscal tear. And this is important because the reason, like if you say that there's a locked knee, it can be because of pain, which is not the same and not what we're after. What we are after is the mechanically locked knee. And the definition is that they cannot extend fully. So this is where you really need to put your palm, flat palm, underneath the knee of the patient and make them try to extend their knee towards your palm. And if they cannot touch your palm, then you should assume that it's a locked knee. Of course, with the right kind of injury as well. The ACL and the meniscus injuries are usually these kind of twist motion injuries. Also, always compare with the other side, of course. There is one test that I have a picture of here that we haven't talked about, and I don't think this is particularly useful with the locked knee, but if you have an ACL tear, then the usual test would be the Lachman's test. And as we talked about, the Lachman's test has a high inter-rater reliability, and this test seems to be better according to the EM cases podcasts. And the way you do this is by having your fist below the upper calf of the patient, and then you just push on just above the knee on the thigh. And what you will see, if the ACL is intact, meaning that there's a bridge between the tibia and the femur, then you will see that the leg will go up. If there's no such thing, if there's no ACL, then it will not go up. So it's quite an easy test to do. I've performed it myself several times on different people, and it's very visually appealing to see this. And I think that's part of the reason why it has probably has a higher or better inter-rater reliability than the other tests. So you might consider that next time you think the patient has an ACL rupture. Other things that might say that the patient has an ACL rupture, besides the history that we talked about with the sidestep motion, then it's the fact that they might have they have a swollen knee almost right away. So they come in with a swollen knee, having made a sidestep movement, and if you drain the knee, usually, you might see blood. If there's fat in that blood, then you will think that there might be an avulsion fracture, maybe a Segon fracture. That's usually, I think, in children, but anyway. And yeah. But the locked knee, back to that, the locked knee you'll need to refer those depending on local guidelines, but usually quicker, much quicker than the usual meniscal tear or ACL ruptures. Yeah. And the levator test, or the Lely test, was this one. Yeah. Okay. Then we come to a rare but really, really important topic. that we should be able to pick up, and I was blissfully unaware of before going into this deeper dive in orthopedics, the dislocation of the knee. And what the reason why it's important is it's both a commonly missed thing, and it's also often a commonly underappreciated or underestimated thing, because these patients have a high risk of vascular injury. Also, just much like conditions like subarachnoid hemorrhage, around 50% of them will look normal when they are in the emergency department, meaning that the luxation or the dislocation has reduced by itself. So it's rare, or it's not uncommon to you might see these where it's obviously dislocated, but usually, or at least as usually, you'll see that you have maybe a swollen knee, but not any obvious dislocation. That's why it's often missed. The reason why there's a vascular injury involved with this is the popliteal artery here, and then this graphic shows pretty well, I think, that you can create a tear when it's dislocated, especially if it's dislocated forward, the femur. Okay, so who gets this? Well, it's either people in high velocity trauma or high energy traumas like traffic accidents, or people with a high BMI in low energy trauma, and that's probably the population that most of us are going to see. So it's important to so your above average like high BMI patient who's had some kind of twist or like fallen with their entire weight on their knee, you have to think about this, especially if they have a history of where they say, oh, there's it went out and then it went in again. The risk of if there is an injury to the vessels, then according to EM cases, there's an 85% risk of amputation. So and the time to revascularization is 6 to 8 hours. So it's really important that we catch these. So how do we do that? Well, if we can clinically have like the main point about the clinical examination is besides the history of a high BMI patient who said that the knee jumped out and then it jumped in again, it would be that when you examine the patient, you'll have 3 of the 4 ligaments like being loose or off. So that would be ACL, PCL, MCL, and LCL. 3 of those. If 3 of those 4 are off, then it's a problem. Then it's a dislocation until proven otherwise. Also, when you do your straight passive leg raise test, or maybe active leg raise test, but if they can't do it actively, then you'll do it passively. If you do that, then you'll see that there's hyperextension, like the knee is hyperextending down when you're doing a straight leg test, and you might have obvious signs of neurovascular injury, such as nervus peroneus injury, meaning that you'll have a drop foot. Then what you will do when you see this is that you will reduce it if it's not already reduced, and then you will meticulously see if there's perfusion, and you will do that by checking the vascular status by the just as I showed in the first part of this lecture. It would be Doppler, it would be serial pulse checks, but most guidelines suggest that you do an ABI, and if the ABI is normal, then it doesn't rule it out. but it's and that therefore you have to have serial ABIs, or serial vascular injury assessments. So these patients always have to be admitted for that. Some places will do angiographies, and these are not 100% sensitive either. So no matter what, they'll have to be admitted. In the next slide, I'll show you an algorithm from the Danish Orthopedic Surgeons Society about this here. So if you have someone who has a suspicion or an obvious dislocated knee, then you'll check for vascular trauma, ischemia, weakness of pulses, or asymmetry of pulses between the healthy side and the unhealthy side, or an expanding hematoma around the knee, meaning that the vessel is off. If they don't have any of those, then you'll do an ABI. And if they have an ABI for 24 hours, and if you have the ABI and that entire time above 0.9, then it's unlikely with a arterial injury. If it's below 0.9, of course you have to maybe I would suggest that you compare with the other side, because they might have background ischemic injury as well in their legs, so they might always have an ABI of below 0.9, but check with the other leg as well. If they have that, then you'll go to the CT or MR of the arterial with arterial phase angiogram, and then that will decide whether or not there's an arterial injury that has to be done something for. If you at any point find convincing evidence for arterial injury, you have 6 to 8 hours to fix it, and that's where you go to the vascular surgeons. All right. As for the dislocation, I would suggest checking local guidelines, but probably it's some kind of immobilization with weight bearing, I would imagine. There are very few totally immobilizing injuries with the knee. I think one of them is gastrocnemius tears, but check the local guidelines for those. Yeah. In certain local protocols, the guideline here says that you could go to the CT right away, but really depends on, even if that's negative, probably according to EM cases, it's not enough early on to rule it out. So. Okay, we talked about the ACL tear before, and I'll just quickly summarize that. Usually it's this sidestep twist injury with deceleration, usually handball injury in Denmark. A lot of people feels like a pop in their leg, around 70%, and a feeling that they cannot trust their leg, and then there's a swelling right away, as opposed to the non-intra-articular ligaments such as LCL or MCL. All right, or meniscus injuries as well. Then you might do this test. You might take the swelling off the leg by doing an arthroscopy, arthrocentesis, and usually, like the main point from our lectures about the ACL rupture was that, I mean, even if it's off, it's really training. That is the most important thing, and you have to intensely train it for 3 months before considering operation. And you can be a high-level NBA player without actually having your ACL. So it depends on the function level of the patient. Whether or not you do the operation, and I'm not aware of the benefits of the operation. Then you have your quadriceps and patella tendon ruptures. These are usually something that requires operation within 1 to 2 weeks, and that's why we need to pick them up. There are usually acute knee pain, and then they won't weight bear on the leg. There's no real swelling because it's not an intra-articular injury. They might have had subfluoxetine before, but not necessarily at all. usually if there's these two types. There's the quadriceps tendon and there's the patella tendon. And if it's the patella tendon that is intact, then you'll see the patella being pulled down, and you'll call that a patella baja because the patella is going down, and that means that you'll have a gastrocnemius tear, a quadriceps tendon tear. And if it's the patella tendon that is off, then the patella is being pulled up, in Spanish alta. That's why it's high there. It's usually the quadriceps tendon rupture, the patella baja, in above 40, and below 40 it's usually the patella tendon. Okay, so the diagnosis is usually quite obvious if you do the straight leg test, where the patient tries to lift their leg, and of course if they cannot stretch their leg because of their quadriceps isn't engaging, then that you have your diagnosis. Sometimes you might feel a lack, like you see here. If they have a hard time doing this lying down, you can also sit them on the bed and see if they can stretch their leg from there. It will do the same thing. They cannot extend their leg. It's important that they do not use their abductors or their rotational force in their leg, in their hip. So they have to you have to make sure that they don't do that to quote unquote cheat with this test. Yeah, so that's the quadriceps or patella tendon rupture. All right, now we'll go to some of the more common. And I realize that the ACL rupture, of course, should be here in the more common, but I guess I took it into the don't miss because of the locked knee. I just wanted to give you some information about that. Okay. So let's see here. Here we have that algorithm that, or a bit changed algorithm from what I've from some of the Swedish guidelines on this. So if you have a traumatic swollen knee, the swollen knee is a category of their own, and you might have a atraumatic swollen knee, and that's where you have then you go through your monoarthritis algorithm and see, could this be septic arthritis? Could this be, well, depending on the age of the patient and so on, could it be gout? Could it be crystal, like pseudo gout? Could it be anything else like that? But now we're talking about the traumatic knee, meaning that you either you hit your leg or you twisted your leg in some way. There are some variables here. Either it's a swollen or not swollen knee, even this is stable or an unstable knee, meaning that 3 or more ligaments are off. And then you can have a locked or not locked knee. So these are some of the important distinctions when you have a traumatic swollen knee to be aware of. Then you have these diagnostic tests to do. You can do an arthrocentesis, which I'll show on the next slide how to do. You can do an X-ray, which you could or could not use the Pittsburgh knee rules for, or the OF+N knee rules, depending on what your local guidelines are. And you can do your clinical examination, which was important for the stability, even though it might be hard. And then you might have different outcomes. So if you have a swollen knee after a few hours, cannot walk, and there's blood, then you'll think of an ACL rupture. And this is important that with children, the ACL, if you have a swollen knee with blood in the leg with children, it's important to do the MRI quite quickly, because there might be a cartilage damage or an eminentia injury, as I understand it. The PCL ruptures are rare and usually don't are more obvious from history. Then you have your unstable LCL injuries we talked about. Usually they will not have any hydrops or any swelling of the knee because they're extra-articular. and these are the like level 2 and 3s that you have to check up. And you have your MCL, they heal better, and they're usually not something that has swelling either. Then you have your multiple instabilities, and I mean, a lot of the Swedish algorithms go by whether or not there's blood or fat. As a general rule, if you have blood in your in the swelling, if the swelling is blood, then something has ruptured, meaning that it might be a fracture or there might be a ligament, a cruciate ligament that has ruptured, some kind of intra-articular thing. The other thing about that is you can, when you draw the blood out of the knee, then you can check for fat droplets. And if there are fat droplets, then it's highly likely that it's a fracture and not just a ligamental. And for certain conditions like children's patellar luxation, it might be this show you that, well, then they need an MRI even faster than if it was blood without fat. But I guess these are not that precise tests, I would think. So this is just to show you that there are more sophisticated ways than I've been taught in Denmark to approach the swollen knee in the emergency department, and different cultures, different places, and it varies. And this is very much based on doing an arthrocentesis. There were certain arguments for doing the arthrocentesis besides the diagnostic value of it, and that would be like the diagnostic value would be to see if there's blood or blood with fat. That would be useful, especially if the X-ray is somewhat occultly negative. But it's also important so that you can examine the patient decently for stability, for instance, and assess whether or not they have locked knees decently, because you cannot extend if you have a very swollen knee. But another argument that was posed on the course for doing this was the treatment part of it, the therapeutic, because doing arthrocentesis, like if you have a swollen knee, it takes a while before it's not swollen anymore. And as we talked about in the beginning of this lecture, immobilization and not being able to move will reduce, will induce sarcopenia quite fast within weeks, and the rehabilitation of that might take a long time. So they said that it was like at least a nice thing to do for the patient, because then they could move quite fast and didn't have to deal with the swelling for too long. Especially because the risk of infection is quite low, as we'll see in a minute. I think I'm quoting a Danish study here. So we'll just move to the next slide here. Oh yeah, exactly. If they were stable with hemarthrosis, 4 weeks follow up with ortho. These like more syndrome, more so than diagnoses, and that might be actually more relevant for emergency physicians. So if you have a stable knee with hemarthrosis, 4 weeks follow up with ortho, because that's probably just an ACL rupture, especially if there's X-rays negative. If there's fat in it, then it's a different story. Then you might think all cold fracture, and you consider whether you should do a CT or something like that. Stable with no swelling, negative X-ray, that you can follow up with your private practice physician. Locked knee, also follow up quickly. And if you have an unstable, then it's usually a ROM walker, and follow up within follow up with ortho. And unstable can be just one ligament that is unstable, like grade 2 to 3 LCL. Yeah. Then you do the arthrocentesis, and we talked about the benefits and then the harms. And what I'm usually told is, well, there's a risk of septic arthritis, and the best study I could find about this was Peterson et al. 2019, where they did they did this sterilely, and they checked retrospectively all rheuma and ortho patients in the department setting. So not an emergency, not entirely at least, in the emergency room setting. but they had a lot of procedures, like almost 22,500, but yeah, 22,370 procedures. So 2/3 of these were injections, so, and one third of these were arthrocenteses, but like all of them, a needle in the joint, a sterile needle in the joint, and of all of these, 11 patients were later diagnosed with septic arthritis. Yeah, so retrospectively, it's a very, very low number, and I would be quite confident to do this, even for minor things such as pain and quicker mobilization. I think it seems like it's a decent thing to do, actually, but it depends on local culture and whether or not you have the time and culturally backing to do this. Okay, so how to do it? So you position the patient in this semi-flexed, or as I say, there are different ways of doing this. I'll just show you the medial way, but there are also a lateral way and probably others as well. But you'll place the patient in this semi-flexed position with a cushion below and a bit outward rotated knee. Then you'll it's always nice to tell them about the harms and potential harms and benefits of doing this before you stick a needle into the knee. Then you'll do lidocaine in the skin, and then you'll sterilize, and then you put on your sterile gloves, do the arthrocentesis, where you've measured just 1 centimeter below the edge of the patella. You can feel, especially if there's large swelling, it's quite easy. And then you go straight in parallel to the patella, and then you aspirate as you go in, and then you aspirate, and then you can send it off to whichever tests you need. Oftentimes it's just a macroscopic test to see, and then you'll spray the blood out into into some kind of bucket, so that you can see whether there's fats among fat pearls among the blood or not. Yeah. Yeah, tibial fractures. They are one of the more common fractures. We saw it at the top 10 fractures. There are certain children fractures here that I will not go into, but we'll go into later on, such as the toddler's fracture. But these are often. It's important to know that if you have a fracture in your lower leg on the tibia side, you'll think open fractures, and you'll think compartment syndromes, because these are common places for both of them. If you think of the tibia, if you ever played football, then you'll see, like, when you have your shin protections on, you you know how close to the surface that the tibia is. So you really don't want to get hit there, and so when it breaks, there's not a lot of skin to actually keep it in. So that's why it's often open fractures when you have these fractures. The proximal fractures around the knee are like the medial plateau fractures are quite easy to find usually, but the lateral plateau we've been through are often hard to find, and I've showed you some tricks to find it on a conventional X-ray, but sometimes you need a CT, at least a CT to like see how big the injury is once you find it. You have diaphysis, like the shaft, the middle of the and then these are the ones that are often open fractures, often with compartment syndrome. Okay, we move to another region now, and then we'll have a break until we go, and then we'll go to the next the last lecture about arm, back, and children. Okay, so hip and pelvic region. So anatomy-wise, I don't have too much to say here. it's important to, when you examine your patient for hip fractures, especially the ones that are not obvious, to do decently rotation of your hip, of the patient's hip, and like um, it's always a bit hard to know what is external and internal rotation. So I usually use the lower leg to guide me. So if you flex the patient's knee and hip, and then the lower leg will point towards the side that is turning respectively inwards and outwards. So if you have if your leg is turning that way, then it's an outwards rotation, and if it's that way, then it's an inwards rotation. Okay. So your inspection is usually you can check if the patient's leg is outwardly or inwardly rotated spontaneously, and how they're passively lying with their leg, especially if it's traumatic. If it's non-traumatic, such as children or potential septic arthritis, then you will try to open up their knee. If they have like coccygeal simplex, then they will try to open up their hip joint to reduce the amount of like pain or swelling, so that there is space in the hip joint, and it's important to see how they're lying with their hip. Palpation, I don't find too important for the hip. You'll do it, but I find it quite hard usually, especially on demented old ladies, to actually get a decent distinguishing power in this examination, and that's why I usually go to the internal and external rotation of the hip, and usually actual compression, and see whether they are hurting or not, and see whether or not they can actually walk on it. The ones that you don't want to miss are your especially the occult hip fractures. So here we have two patients, the one with a shortened and externally rotated leg, and the other one with a shortened and internally rotated leg. And which one is which? Then you can pause the video to think about that. But it's quite classical, so I'll just give it away here. This one would be a fracture of the hip in the right, of course, in the right context, and this is a hip, someone who has an artificial hip where it's dislocated. What is important is that hip fractures are usually for young people, high energy trauma, and young people will often need a CT if the X-ray is negative, and elderly people will need an MRI if the CT, if the X-ray is negative, but you have a high suspicion. And I guess the theoretical reason for the distinguishing here is that usually with young people the cortex is involved, and with older people the cortex is not involved. And that's why you need the MRI to look into the bone, and the CT could look on the outside. This is something they told us at the course. I don't think that has too much importance for the average emergency physician. What does, however, have a lot of importance is that a lot of hip fractures, hip pain, especially in children and elderly, will radiate as knee pains. So this is where if they say they hurt their knee, but you cannot reproduce the pain, then you will think of hip. Okay. So the common fractures there are. Okay, so let's go to one of the bread and butter diagnoses, the hip fracture. I think before just going into all of this hip fracture, I think it's important to always think about what's the mechanical quote-unquote mechanical reason for their fall, as we talked about the geriatric decompensation patients, right? So that's always something you have to consider, and we'll go through the management of the hip fracture right away here. But let's go through the fracture types, right? And why is this important? Well, for the emergency physician, it's not that important, but there are certain details that your orthopedic consultant usually are grateful for knowing, especially the patient's biological age and functional level. Is really important for them. So let's just go through these, and then we'll see whether or not you find it useful. The cervical fractures, the neck fractures, are usually always needs some kind of fixing operatively. And they're diagnosed by the Gardner, or usually the classification that you might know is the Gardner classification, which is according to our lecturers, rubbish because it's an old relic. It's descriptive and doesn't correlate too much with the treatments, and it's also only something that is like the classification only goes by anterior posterior views. It doesn't mention anything about lateral views, but for you it's really important to look at the lateral view, because sometimes oftentimes you can only see that the fracture is dislocated on the lateral view. Okay, but that's not included in the Gardner. Okay, so cervical, like the hip neck fractures, they are quickly just dealt into dislocated and non-dislocated, dislocated and non-dislocated, and that's mostly the most important thing. So is it still somewhat articulating or in plane, or is it like translated, the Lara thing that we talked about for is it angulated, is it like off to the side translated? All right, so for the not dislocated, for the good ones, so to speak, then it depends on the biological age. If the patient is biologically young, then usually you can do an osteosynthesis, which will, I think, make them more functional. But the problem with this is that, and that's why the biological age comes into play, is that it'll have to go out for revision a few years later. So that's the actual reason here is that can this patient go through an operation in maybe 5 or 10 years? That's what you're actually asking. And if they can, then well, yeah, then you can sign them up for that kind of operation. The biological old will get a hemi-hip replacement of some sort. And I'm not going into details on what kind of screws or what kind of hips you're going to. That's for the orthopedics to decide, or orthopedic surgeons to decide, of course. But just like to know why the biological age is so important in these. If they're really young, then you may, and it's not dislocated, then you might consider following them up really closely if it's stable, and then see whether it heals, so that they don't have to get a hip replacement. But that's really uncommon. And if they are really young and get a hip fracture, then you should work them up for some kind of osteoporosis, because that's quite rare, unless it's a high velocity trauma, of course. Okay. The dislocated, they'll have cement and hip replacement of some sort, and there is some difference between whether they're biological young or old. If it's really dislocated, then there's not much to do. It's never conservative management, because there's the head will as I understand it, be necrotic because of the vessels going through it. You can think of stuff like calvitic parietus or epiphyseal lesions. So if you get like necrosis of this area, then the entire hip dies, as I understand it. So there is one other exception besides the very young, and that would be the palliative, where they usually do some kind of operation for pain management, depending on their how long they have to live. But yeah, okay, so that's the cervical, and that's the big one. And if it breaks here in the neck, and it's intracapsular. Then you have your your extracapsular ones, your per trunk PTFF, your per trochanter fracture, which is usually a bit of depends on local routine. It's not uncommon; it's quite common. But then you have your, I think it's one of the Big Ten as well. But then you have your subtrochanter. That's more uncommon, and usually there are different there are different ways of doing that as well. But it's never wrong to do a marrow speak. We were told. Okay, on to more emergency physician important stuff. Because how to manage these hip fractures is always important to know why did they fall, and we talked about that for the geriatric syndrome management. And you have to pain manage them, of course, with nerve block and morphine and Movicol and also antiemetics. Then you have to something that we not always think about in the emergency department is that they usually, it's always hard to know, are they going to get food, are they going to get operated on today, or are they fasting all the way through tomorrow, and then maybe it will be postponed, and then an elderly lady of 85 won't eat anything for 2 days. So it's important to just give them something, some kind of glucose, and like 5% glucose is only 200 calories. So give them something in the emergency department, and optimally you have some kind of system worked out so that your patients won't have to fast for too long if their operation is unlikely. So, but not all places have that. So just bear in mind to give this or give something for them. And then, of course, they have some kind of preoperative prophylaxis. That's not always the emergency physician's responsibility, but some kind of anti-DVT treatment, and then some kind of antibiotics as well. Your femur fractures are usually high velocity or special cases, such as steroid use patients where the only femur fracture I ever had, a patient I ever had was a patient who had all their life been treated for some kind of rheumatic disease with high dose steroids, and then it just spontaneously broke off when they were walking or hiking, and just terrible experience. I imagine if your leg just breaks off suddenly, but it's usually like that's a special case, and usually these are special cases, and femur fractures are usually something that has to be stretched out so that it reduces the bleeding, because they can bleed a lot, as we know from ATLS or ETC courses. It's also important to know whether they have a hip fracture, hip replacement since before or not, because they might have some kind of breaks in that as well. So it's important to think of doing an X-ray of the entire leg. Then you have your pelvic fractures, and these can be dealt into high energy or low energy. And if you're really interested in these, I think they're really interesting as well. But I always found them quite hard to get my head around during the ATLS and ETC courses. Then I suggest that you check out Intra-Anest, which is a great YouTube channel about traumatology, anesthesiology, and a bit of emergency medicine as well, from Lund in Sweden. They have English lectures, but most of them are in Swedish, but they're high quality. And there's a great series on high risk orthopedic injuries, which I can really recommend. And in that series, they talk about the hip fractures as well, but also a lot of other high velocity risk injuries. Which I might go through in another lecture when I do the ETC ATLS kind of lectures. All right. But if you have a high energy pelvic fracture, I'll just mention quickly here, there is almost always other injuries. You should, of course, you could use the it's always like you have a high velocity trauma. The patient is usually hypovolemic, and they will be tender over the hip. They might have a declubbing injury, and you should not push on the hip too much. Only one experienced surgeon should do that before the patient lies on the stretcher comes from the ambulance and lies on your stretcher or your bed, you should have in place a pelvic binder, or what you might call more appropriately a trochanter binder, because you need to put it on the trochanters, not the pelvic area. All right, and when you put that on, you will check for the 5 P's, the pulses. You check for pulses, yeah. You'll check for pockets so that they're empty, so that they don't press. You'll check for the penis, so it's not in the way. And you'll check the pelvis, so that you're sure that it's on the trochanter and not anywhere else, and not too high and not too low. And you'll check the pulses again once you've strapped in. Okay. Usually these injuries are either dealt into vertical or anterior posture, or shear injuries, and they have a high mortality because they bleed. The venous bleeding inside the pelvis is usually quite hard to get at, and you might in hard cases use if the pelvic binder doesn't help, you might use ribor or ligation. I won't go into more details about this because I will do a lecture another time about high risk traumas instead of this one. It was just minor trauma. Okay, so going on to this lecture topic, the minor traumas. You will usually be the elderly with a lateral compression fracture, and these fractures almost always are conservatively managed with painkillers and so on. It's really important that they get up and walk, because if they cannot walk, then we should consider doing a CT, and then you can consider doing an operation even on quite biologically aged patients, because it will heal faster and the immobilization kills. I haven't mentioned the mortality rate of the hip fractures and some of the pelvic fractures as well, and this is not necessarily causal. I mean, it's not the hip fractures that kills the patient necessarily. But it's because a lot of these patients, the reason why they end up having a hip fracture is because they're frail, and they don't they're frail enough so that they hit their hip and don't foosh, which is a test somewhat in itself, in and of itself. But mobilization of this population and all of the geriatric management that is important for these patients, and really important to get decent painkillers on board and decent laxantia and decent antiemetics on board really quickly, so that they can mobilize. That is the most important, because the longer they stay in bed, the higher the risk is for a lot of other injuries. And don't forget the psychological impact of these things on patients as well. It's massively problematic for them usually. Okay, then just one pearl here that almost never, it's almost never simultaneously hip and pelvic fractures. Is usually either one or the other. Okay, so this is the end of this part of the lecture. We'll go on to the arms and back and children in the next part of this lecture. Thank you.